Hello, everyone. Welcome to the 2022 ICES Research Forum, Data for Impact, Informing the Future of Health. I'm delighted to have you join us today. I'm very excited about the day ahead of us, and I can't wait to get going. So I'm going to start with a land acknowledgement. I am today in Toronto, but as I make my land acknowledgement, I invite each of you to reflect on the land where you are located and make your own appropriate personal acknowledgement. Toronto comes from the Mohawk word tikaronto. It means the place in the waters where the trees stand. And I'm fortunate to be sitting in an office and looking out over a beautiful ravine filled with trees. I want to acknowledge and honor the fact that where I am today is the ancestral home of the Mississaugas of the New Credit, the Haudenosaunee, the Chippewa, the Anishinaabe, the Huron-Wendat, and that today many other First Nation, Métis, and Inuit people call Tikaronto home. Next, I'd like to introduce Elder Wendy Phillips, who you will know from previous ICES research forums. Wendy will lead us in an opening prayer to help clear our minds in advance of a great day's discussion. Wendy is of the Bald Eagle clan, a Potawatomi and Ojibwe, and a proud member of the Wasauksing First Nation. She's a graduate of Trent University, Fleming College, and George Brown College, and is a founding member of the Indigenous Innovation Initiative. Over to you, Wendy.
Miigwech. Bonjour. Megzi Dodem. Widow Kaza Bajgal Indigenous Wasauksing Nidunji Indian Dunjaba. Jaman Mak Parwadamin Dao. Chimigwach Kinagego Bajik Tol. Chimigwach Nishangishgat. Chimigwach Atsokanak. Chimigwach Wabanomado, Jamanomado, Shminchmak Mado, Giwan Mado. Chimigwach Aki. Chimigwach Nimki Beneshi. Chimigwach Bajikan. Chimigwach Mishomas Nokamas Wanana Bojo, Nwabe Swabe, Nishode, Shikaka, Mamagwa Swanishnabe Sak. At this time, we give our acknowledgements to the one that has created everything and everyone for this good day. And we give our acknowledgements to what we describe as the four directions. And so at this time, this is a very important concept, especially in our present day society. And this is what I wanted to acknowledge, especially when we talk about respect and when we talk about inclusion today, that for us, our creation story includes all of our human family. And so it speaks about those four races. And so we give acknowledgements to those four directions and those four races and our human family. And we also give acknowledgements to the earth. And this is for us a very important concept that we are to always take care of her. And she gives everything and everyone life. So she's the one that we're to also care of and think of. We also think of the thunder beings. And we also think of those beings that have come before us. So at this time, I'd like to say Gichimigwech, a big thank you for the staff and all the work that has gone on that we often don't see. And we also give acknowledgements for everybody coming today. And we ask that when everybody comes together like this, that we all come together with a good mind and a good heart and a good spirit. And that we understand that it will be a lot of listening today, and that we have different ways of listening, and that we usually listen with our minds and from an Indigenous or Anishinaabe way of thinking. And we also describe as well with that two-eyed seeing is that you can also listen from your heart. And so that's something we often ask people to think about when you're learning things, is to be open to learn in different ways. And so we ask people to remember that we understand, the different topics that do come up, that some of them are sometimes difficult to to think of them in different ways, but that's what we ask people to be open to those possibilities. So at this time, we say Gitchi Miigwech for all those aspects of ourselves, and we also give acknowledgements as well to what we describe are some of our aspects of healing and how we're able to help one another and ensure the health and well-being for future generations. And this is for us, what we think about is this good health and long life, and that these things we need to work together and be able to do those things in a good way. And this is what we describe within our relationships is for us to take care of one another, that we need to do that in a respectful way. And so this is some of the things that we speak about whenever we come together, that even though that we may come from different parts of Turtle Island or the world, that when we gather, we can gather in a good and safe way. So those are the things that we ask for when we come together like this in such a large population for this gathering today. That it's really exciting to hear that there's many of you attending, and that we remember, the people that we serve. And it's sometimes we often forget about the humanness, and that's something we need to remember as well with the work that we do. And so we say Gitchi Miigwech, a big thank you for all these things that we have mentioned and all those things we haven't as well. And that we ask that everybody will be able to enjoy their day and be able to enjoy our time together. So we say a Gitchi Miigwech and a big thank you.
Thank you, Wendy Miigwech, for that opening prayer and thoughts, and helping us reflect on today's discussion and to prepare so thoughtfully. Thank you. And we'll hear again from Wendy at the end of the day as we close out the research forum. So once again, welcome to the 2022 Research Forum. Again, this year we're meeting virtually. I think we all wish we could be together in person for an event like this, and let's hope the next year we will be, at least some of us. But I think it's also important to note that by virtue of this virtual conference, we can have more people attend from more parts of Ontario and across Canada and internationally with a much lower carbon footprint than if we had a fully and only in-person meeting. We're at almost 700 registrants for today's conference, and so we can definitely celebrate that. And of course, there's much more to celebrate this year. 2022 represents the 30th anniversary of the founding of ICES. Now, I'm not sure whether David Naylor, the founder of ICES, imagined what the institute that he launched in 1992 would look like 30 years later. To try to get a handle on that long story of ICES over those 30 years, I dug into the archives and pulled out the annual reports going back to that very first year, many of which we have only in hard copy, and for some of which we have only one single hard copy. But in going through those reports, it was a pretty interesting story that emerged. First of all, the original focus way back in 1992 was clear, quote, ICES supports a health services research agenda to promote effective, efficient, and equitable medical care. Pretty clear and straightforward, if a little limited. The growth of ICES since that first year has been steady and inexorable no matter how you count it, whether it's the number of scientists, the number of staff, the number of publications, the grant dollars secured, data sets and the complexity of the data sets that are available for researchers, the methodologies that have been developed and deployed, the physical sites that are now part of our network across Ontario, the number of remote virtual researchers accessing ICES data, the growth in our stakeholders and partners, and the depth of those relationships all have steadily grown. And most of all, so has the impact of the research and analytics conducted. The milestones achieved over these 30 years are many, and it would take the whole day to list them all. So I will spare you that. But let me just hit a few of the highlights and apologies to anyone who feels that I left out one of their personal favorites. It was really very, very hard to choose. ICES had healthcare system impact right out of the gate. In the early 90s, we published the very first maps of medical practice in Ontario, along with the first practice atlases, describing wide variations in healthcare utilization and outcomes across the province. This led to unprecedented public awareness and responses, such as internal audits at hospitals, as well as systematic efforts by medical societies to address this unwanted variation that had been revealed. Fast forward to 2019, and ICES scientists were publishing tools to help clinicians at the bedside. For example, a tool designed for use in the emergency department to help clinicians assessing patients with congestive heart failure decide who needs to be admitted to hospital and who could safely be discharged home. This online tool has been endorsed by Ontario, Canadian, and international groups for use in clinical care. How about impact on health policy and other policy areas? Well, ICES research contributed to a landmark decision to withdraw Vioxx from the market by Merck based on safety concerns over the drug that had been revealed in part by research carried out at ICES. ICES scientists also provided key analyses and guidance for the design of the Ministry of Health's regional health units, the so-called local health integration networks, when the ministry moved to a regional health model. And then over a decade later, when those regional health units were dissolved and Ontario moved to an Ontario health team model, again, ICES scientists provided key analyses to support the identification of the populations that Ontario health teams would serve. More impact. Groundbreaking research at ICES found that driving while using cell phones was associated with car crashes, injuries, and deaths, and helped to lead to changes in legislation in Canada and many other countries. In 2009, critical policy evaluation of the more than $1 billion that had been invested in Ontario in primary care reform showed that, in fact, chronically ill and lower income people were actually less likely to benefit from those reforms than others. Over the last number of years, substantial research on prescription opioid use has helped to drive rapid, targeted regional responses to the opioid crisis and informed Ontario's strategy. And ICES North researchers have also led important studies on methadone maintenance treatment in managing opioid addiction. How about during COVID? Well, there would be so much to describe. There is so much to describe, but let me just pick out a couple of highlights. In 2021, ICES published regular reports at the neighborhood level on the rates of COVID-19 cases and eventually on COVID-19 vaccination uptake, showing disparities with lower income and more racialized communities having higher rates of illness and lower vaccine uptake. Public health responded to these data and adjusted COVID-19 testing and vaccination strategies, and these disparities lessened. In addition, an ICES Western study showed that people experiencing homelessness were far more likely to test positive for COVID-19 than were others and had far worse outcomes. This study was presented to the Prime Minister as part of a roundtable and resulted in changes to Toronto's approach to vaccinating individuals experiencing homelessness. More recently, in January of this year, ICES McMaster researchers published a timely paper in the New England Journal on the safety and use of mifepristone, an oral drug for medical abortion, in Ontario after that drug became available without prescribing restrictions. They demonstrated its safety and efficacy and found no increase in overall abortion rates overall. These authors have been asked to present their results to the Food and Drug Administration in the US, where the drug is often still restricted, and clearly this study is important information in the fraught debate around abortion that's currently underway in the United States and elsewhere. Finally, how about the impact on individual health? Well, in 2013, there was a landmark study that showed that people who live in more walkable neighborhoods were less likely to develop diabetes, demonstrating the importance of built environment factors, among other social factors, on individual health. ICES Ottawa researchers also developed an online calculator where Ontarians can go, or anyone actually can go online, enter their health information and lifestyle information, and have an estimate of their life expectancy, as well as get advice on how changes in lifestyle could help improve it. And recently, an ICES U of T landmark paper in Nature that used machine learning methods in our high-performance computing environment on over 1 million Ontarians to develop machine learning methods to predict adverse outcomes due to diabetes. Over this period, ICES has grown considerably. Our network first grew in 2007 with the launch of a satellite, what was then called a satellite site at Queen's University in Kingston. And these would be followed by additional sites in Ottawa in 2010, Western University and the University of Toronto in 2012, McMaster in 2016, and finally ICES North in 2018. Partnerships with university and research institutes were critical to establishing these sites. And partnerships and stakeholders have been critical to the impact of ICES from the very beginning. The number of stakeholders have grown, and so has the depth of our relationships with them. For example, partnerships and funding from the Ontario Sports Support Unit and the Ministry of Health enabled ICES to further increase access to data for researchers through the 2014 launch of Data and Analytics Services. For the first time, researchers anywhere in Canada, regardless of whether they had any relationship to ICES, could have secure remote access to ICES data to carry out research and analytics without needing any ICES appointment and without needing to set foot in an ICES physical site. Our close work with the Ontario Sports Support Unit also enabled ICES to create its Public Advisory Council, which has provided key guidance to ICES to ensure that the ways we work with data align with the values of Ontarians. For over a decade, we've developed key relationships and partnerships with First Nation, Métis, and Inuit communities and organizations in Ontario, including the Chiefs of Ontario, as well as with the Métis Nation of Ontario, to enable ICES to responsibly and ethically support Indigenous-led health research and support Indigenous data sovereignty. Partnerships with the Ontario government and the Vector Institute have enabled the development of the HIDAP, a high-performance computing center to enable machine learning and artificial intelligence analytics at ICES. More recently, ICES has been a key partner with the Ministry of Health in establishing the Ontario Health Data Platform, an even more ambitious effort to enable AI and machine learning analytics. Finally, partnerships across Canada led to ICES being in 2019 a founding member of Health Data Research Network Canada, a pan-Canadian organization dedicated to enabling researchers to more easily undertake pan-Canadian research. The way ICES has responded to stakeholders and helped answer questions of importance to them has also evolved. Believe it or not, in the early 90s, we had a fax on demand service where stakeholders could request published information on healthcare questions and get responses from ICES faxed to them. Well, I'm happy to say we retired the fax machine a long time ago, earlier, in fact, than hospitals have retired fax machines, I'll add. And then for a time, we offered an online analytics tool called InTool that had limited aggregate data analysis available. But since 2012, in partnership with the Ministry of Health, we've had the Applied Health Research Question Program, which has been highly successful and which provides rapid response and bespoke analytic reports to specific healthcare and health system questions to which our health system stakeholders need answers. So much has changed in so many ways over those years, yet some things have remained constant. What's remained constant has been our commitment to excellence and cutting-edge research, our commitment to training the next generation of health researchers, our work with partners and stakeholders, our efforts to try to answer questions that matter by translating data into trusted evidence, all in order to make policy and healthcare better and people healthier. Other things have changed less than we might have hoped. For example, the perennial challenge of achieving effective knowledge translation, ensuring that the discoveries that are made actually result in improvements at the coalface. And then there are new challenges. Massive changes in digital data availability, analytic capacity, and expectations for data access, yet a legislative and regulatory environment that is challenged to adapt and keep pace. New threats, such as cybersecurity, which must be managed effectively. An evolution, perhaps a revolution, in how equity must be advanced in our society, and related to that, the need to develop responsible and ethical means to engage with many publics in our work. Our past and present is a strong foundation for the future, which is what we're going to focus on today at the Research Forum. A vision for data science in health systems. The promise of looking beyond health data alone in addressing health equity and how to do so ethically and responsibly. We're going to hear from Alisha Aslam, a remarkable youth advocate for positive social change. And finally, we'll consider the next 30 years of data in Canada with 3 outstanding Canadian and international panelists. We also want to hear from you. We hope to have as many of you as possible participate in the question and answer sessions in each segment. Please note on the platform that you're watching this on, there's a Q&A section where you can enter your questions, and we will attempt to answer as many of them, or have the panelists answer as many as possible. COVID-19 has shown us how much and how fast our world can change, for better and worse. Our challenge is to harness that change and maximize the benefit equitably. Though the phrasing of the vision of ICES has changed over the years, its ambition has remained remarkably constant, that improved health and healthcare for everyone can be achieved through world-leading research and analytics. Today's Research Forum will help us together chart a course based on that ambition. Now, before I introduce the next speaker, I want to thank our key partners who help make the work of ICES possible. First of all, the Ontario Ministry of Health, who has been a partner and funder from the very beginning and consistently over the last 30 years, as well as the Ontario Sports Support Unit, which has been a key partner and funder since the advent of the CIHR strategy for patient-oriented research. So thanks to both of those partners. As well, I want to thank our Research Forum sponsors, our returning sponsor, IQVIA, as well as new sponsors, iSecurity Consulting, Fasken, and Mark and Clerks. And now I'm delighted to introduce Dr. Catherine Zahn, Ontario's Deputy Minister of Health, from our key partner, as I mentioned, who will round out this opening segment with a welcome message and launch us into the conference. Deputy Minister Zahn has a 35-year history of contributions to Ontario's healthcare sector as a practicing physician and in progressive leadership roles at the University Health Network. Before becoming Deputy Minister of Health in September 2021, she served as President and CEO of the Centre for Addiction and Mental Health, CAMH, for 12 years. Throughout her career, she's worked to promote equitable access to healthcare for Ontarians, including those with mental illness. Dr. Zahn.
Good morning, everyone. I'm Dr. Catherine Zahn, Deputy Minister of Health for Ontario, and I thank you for the opportunity to help you launch the ICES 30th Anniversary Research Forum. As a past board member and chair of the board of directors, I have a strong connection to your organization and a great admiration for your outstanding work. Today's Research Forum focuses data for impact, informing the future of health, and I couldn't be more aligned with that direction. ICES is a leader in managing population and clinical health data in Ontario, and your future forward understanding of health data as dynamic and evolving is just what our system needs right now. The central nature of accessible, comprehensive, and timely data was obvious at the onset of, as well as throughout the COVID-19 pandemic. Over these 2.25 years, ICES has had an important role facilitating COVID-19 research to support ministry decision-making throughout the pandemic. Your capacity to link and integrate data sets alongside insights generated through advanced analytics has informed and enabled targeted response initiatives that have had real impact. ICES data and research outputs contributed not only to COVID-19 policy and program development within the ministry, but also to health system knowledge users. In addition, your work has advanced COVID-19 research and analytics knowledge dissemination, and it's informed policy decisions for Ontario's pandemic response. The lessons learned will support a future vision of the health system in Ontario. Better access to data and tools will support all of us to plan and respond to emerging priorities. As a frontrunner for innovation in the use of health data, ICES has had years of experience. You've produced evidence-based resources across a broad range of pivotal healthcare issues that have advanced individual and population health in Ontario. For the ministry, ICES's data and analytics expertise has been invaluable. You've supported Ontario health teams, mental health transformation, Indigenous health partnerships, and many other priorities. As an organization, ICES is a critical component of the health data infrastructure in Ontario, and the ministry is proud to have worked with you since 1992. The ministry established the Ontario Health Data Platform with a vision to democratizing access to data for COVID-19 research. We can build on that in the advancements in technology and data tools to evolve and develop agility in our response to emerging needs and trends to best serve the citizens of Ontario. Congratulations again to ICES on marking this important 30th anniversary milestone. I'll be here with you to help improve Ontario's health data ecosystem.
One.
Okay, thank you very much, Deputy Minister Zahn, for those comments. That's a great way, a great segue into the formal or the meat of the agenda, which we're going to start now with panel one. I just want to quickly mention that at approximately 1:25 p.m., we are going to have a networking /bio /coffee break, so you can factor that into your planning accordingly. The first panel today is entitled "A Vision for Data Science and Health Systems: Key Ingredients for Impactful Research." And I'm delighted to introduce the moderator for the panel, Dr. Susan Bronskill. Dr. Bronskill is a senior scientist and lead of the Life Stage Research Program at ICES, and she's a professor in the Institute for Health Policy, Management, and Evaluation at the University of Toronto. She'll be moderating this first panel. So over to you, Susan.
Thank you, Michael. I'd like to welcome everybody to the first plenary session. We have just under 1 hour to explore this important area together, and we have 3 terrific speakers for you today. Dr. Mamdani is Vice President of Data Science and Advanced Analytics at Unity Health Toronto and Director of the Centre for Artificial Intelligence, Research and Education in Medicine at the University of Toronto. The acronym for that is TCRM. He's going to talk about the types of infrastructure needed for strong data science, using the example of his experience with TCRM. Dr. Rosella is the Site Director for ICES U of T and an Associate Professor in the Dalhousie School of Public Health at the University of Toronto, where she holds a Canada Research Chair in Population Health Analytics and leads the Population Health Analytics Lab. Dr. Rosella is going to share insights from applying machine learning and health administrative data with a focus on where we should be heading in the future. And Dr. Doug Manuel is a medical doctor and professor in the Department of Family Medicine at the University of Ottawa and a senior scientist at the Ottawa Hospital Research Institute. Dr. Manuel is going to reflect on open data science and in particular the tools and teams needed to enable efficient data analytics across programs. These are very simple introductions for these accomplished research leaders, and you can find more detailed information on them in the biographies in the conference portal. Each panelist is going to present for 10 minutes, and then we will collectively take questions. So please post your questions in the Q&A chat box that I think is below the image on your in the conference portal. If you're an ICES staff member, to be able to ask a question, you need to go into the you need to be using Microsoft Edge as your browser and not Chrome. We'll relay your questions to the panel and then discuss as many of them as we can in the time available. So let's get started. First up is Dr. Mamdani.
Terrific. Thank you so much. And I'm sharing my screen. I hope everyone can see it. Yes? Okay, terrific. It's a pleasure to be here. I've been asked to talk about what infrastructure is needed for strong data science. And in 10 minutes, it's a really tough concept to go over, but I'm going to speak to my experience with a few areas. First experience is around Unity Health Toronto. I work at Unity Health, which is a composition of St. Joseph's Hospital, St. Michael's Hospital, and Providence Healthcare in Toronto. And I had up a team of data scientists with a very strong research base, but we're really focused on how do you get solutions into practice? So how do you develop machine learning type solutions and get them to actually help patients? Which is a very different way of thinking about infrastructure than the more academic route. So I also am director of the Temerity Center for AI Research and Education in Medicine at the University of Toronto, which is more research focused. I've had the privilege of being, or I have the privilege of being a senior adjunct data scientist at ICES, a faculty affiliated at Vector, and again, more academic based. So I'm going to go through just a few basic principles first, and then focus on what I think is the hardest one to do. And maybe that'll actually then spur some discussion. And I'm talking about hardest one from the infrastructure perspective. So what is data science? If we look at Wikipedia, the source of all truth, it is defined as a concept to unify statistics, data analysis, machine learning, and the related methods in order to understand and analyze actual phenomena with data. I like this definition a lot more. Hal Varian is a chief economist at Google and a professor at Berkeley. He defines it as the ability to take data, to be able to understand it, process it, extract value from it, visualize it, communicate it. This is a nice visual of what this really is. Data science is very broad. Everything from capturing data. How do you capture it? Do humans enter it? Is it through an automated system? How are you getting the data? Because if humans enter it, there may be a lot of errors and a lot of problems with it. What about maintaining the data? So you grabbed it. Now, do you put it on an Excel spreadsheet on your laptop, or do you put it on a SQL database, or where's it housed? Then you get into processing it. You do some data mining, a little bit of modeling and such. Then you get into the fun stuff around analyzing it. How do you build the models? The hard part then is communicating those models. How do you actually say, well, you know, I built a neural net with 6 hidden layers to a clinician who says, I don't really know what that means. I just want to know, do I treat the patient or not? So how do you communicate things in a meaningful way? And of course, when you try to communicate it, you realize your models haven't really been fed with the right data, and then you got to go right back from the beginning. Nowadays, what people are really starting to get into more and more is artificial intelligence and machine learning and these highly intensive computational tasks, and that has implications for infrastructure. There's a nice paper in the BMJ by Marbeo et al. I'm not going to belabor this, but basically the concept of artificial intelligence is to use advanced mathematics to really identify patterns and relationships in data. Now, machine learning is a process where you actually have more intensive algorithms that kind of learn on their own in terms of what these patterns and relationships are. And deep learning is essentially a lot more data with a lot more complexity. And so people are very, very excited about the potential for these sorts of approaches. I'm going to go through what I think has been, at least in my experience, working in the research environment, working in the clinical application environment, working in a few other environments, what I think the most challenging environment is. And I got to say that's probably the applied environment, not so much the research environment, at least in my experience. This is an actual patient from our hospital from a couple of years ago, and of course, anonymized. The patient was a 73-year-old retired nurse with an inflamed gallbladder, internal medicine patient. She had a diagnostic workup done. The plan was to discharge her home the next day. It was pretty standard. The physician was called at 6:30 p.m. Because the patient had a shortness, suggested signs of shortness of breath, and the clinician ordered x-rays and labs. The vitals were checked twice overnight. The physician was called the next morning because there was a sudden drop in blood pressure. And unfortunately, the patient deteriorated and passed away that day. The family was understandably distraught at the sudden deterioration and said we would never left her bedside. She was suffering. The internal medicine team came to our group at the hospital and said 1 out of 12 internal medicine patients will die in the hospital. So what can we do? And of course, there's lots, right? You could have increased monitoring to every 4 hours, for example. You could have looked for signs of sepsis, initiated antibiotics, called the critical care response team, alerted them earlier, called the palliative care team, could have communicated to the patient. All that could have been done much earlier. The problem is it wasn't, because we didn't really know that patient was going to crash. And a lot of times, by the time we realize that the patient is deteriorating, we don't have much time to react. So the question was, can we predict who will die so we can intervene earlier? So what we've done is we've actually deployed an early warning system. So what does this mean? And this has all sorts of implications for the infrastructure that you build. What this algorithm does is for all of our internal medicine patients, every hour on the hour, so 24/7, it doesn't sleep, it grabs data on all of our internal medicine patients. And it predicts at least 48 hours in advance if you're going to die or go to the ICU. So what it then does is if you reach a high risk threshold, it pages the medical team. The medical team comes and sees that patient, and they have some critical care pathways that then they follow. So we deployed this in October of 2020, and this was to reduce mortality. Fortunately, here's some preliminary data among our high-risk patients. When we look at pre-deployment, right at the onset of the pandemic, we compare our mortality rates among our high-risk patients in this interval, January, March of 2020, compared to the past 4 years of data. We saw a 35% increase in mortality. April to June, we saw many more cases of COVID, a 70% increase in mortality. The summer, July to September, it was a lot better, fewer cases. We still saw a 37% increase in mortality. Then we deployed the solution. And despite many more cases of COVID, we saw reductions in mortality. So we feel that research data analytics can fundamentally help our patients, but it is hard from an infrastructure perspective. And something that I would encourage many organizations to look into and think about a lot more is MLOps, or machine learning operations. And so what is this MLOps thing? It's basically a set of practices that aim to deploy and maintain machine learning models in production reliably and efficiently. Because you can imagine, we're talking about close to real-time data, we're talking about processing through algorithms, before that even cleaning and scrubbing the data, then we're feeding it back into workflows. It's a whole process with considerable implications for infrastructure, processes, and people. It involves all sorts of things like data engineering, building data pipelines, making sure they work properly, feeding that back into production, developing models. It's quite involved. You need a lot of oversight and maintenance of infrastructure to get there. This is where the separation between application and research comes in. Research is often really focused on the model development piece, whereas design and operations is really focused on the applied piece. And some would argue there's a bleed between all of these, and I would completely agree to that. So my last slide is really around data storage, compute, and tools, because from an infrastructure perspective, that's what we typically think about. In today's workplace, well, maybe yesterday's, because we're aggressively moving towards more of a digital workplace. We've really focused on, I'm going to have some servers, I'm going to put it in a certain spot, and I'm going to put data there, and we're going to analyze data. Wonderful. Those times have changed. So now, because we have so much more data to work with, we have so much more compute power that's needed, we have so many more people who want to get on this data, we're struggling a bit. And so now we're looking at cloud environments that have much more capacity for storage and for compute. And some are saying, well, I don't want to go to a full cloud environment. I'm going to create something in between, where I'm going to do a hybrid, where I have something locally and something on the cloud. There are trade-offs to each. For the local on-premise environment, you've got a lot more control, but you have capacity issues. For the digital workplace, where you've got complete cloud, you've got a little bit less control, but you've got much more capacity. And in between, it's a lot more effort you have to put in, but you can come to a happy medium with both. So from a data storage perspective, we always have to ask how much data and what type, because there's all sorts of issues related to data standards, interoperability, data integration, and exchange, and of course, timeliness. If you're not dealing with real-time data, it's a lot easier. Then you get into compute. What types of analytics? Are you doing heavy, intensive machine learning algorithms? Or are you doing standard traditional algorithms that don't require much compute? And how many people? I would argue groups like ICES should be thinking globally. Why aren't we actually working with people all around the world accessing data to ICES? If that's your goal, you have a lot of people accessing data, you need a lot of compute. And so then you actually get into considerations around capacity. And of course, tools, modern tools. We often are used to SAS and such. The computer science world doesn't use it so much. They're more into R, Python, TensorFlow, PyTorch, those sorts of tools. How do they play in your environment? Do they play? If they don't, you might be left behind. So I have to make sure that the environment actually accommodates that. But I would say the biggest driver around the infrastructure and how you shape it is, what's your aspiration? If you want to have lots of data scientists doing lots of intensive work on lots of data, I think you really need to pivot in terms of the old school way of thinking around on-premise infrastructure to something that's a lot more modern. And if you value security, if you value control, there's maybe something in between that you have to go to. So it's just a very quick intro on my thoughts. Happy to discuss further, and I'll end here to give other people time to talk. Thank you.
Thank you, Mohammed. I'm already jotting down my questions. Lots of things I think I'd like to ask you, and we'll go next to Dr. Laura Rosella.
Great. Assuming you can see the screen, good? All right, someone will tell me if not. So thank you so much for this opportunity. I'm so excited to be here with you all and celebrating ICES, an amazing institution. So the remarks I'm going to make today are really about thinking about where we can go next. And the context is that there has been a considerable growth in the application of, specifically, I'm going to talk about machine learning, but all kinds of data science techniques to administrative data like ICS data, but this is happening around the world. And so I just want to pause and reflect on the early days. We are definitely, if we think about technology adoption in the first 10,000 days, if not earlier in that. So we are in the very early stages of this. I think that's important to recognize. What have we learned from these early steps to inform where we're going to go forward? And the context I'm talking about is large linked health administrative databases that contain these billing codes, procedures, geography, demographic information, more information which are coming on, which I'll talk about in a moment. So contrast to other applications, I think when we talk about data science and health, we're imagining, the type of clinical data Mohammed was talking about and all kinds of other information. I'm going to try and stick to the context that we're mostly working in. And so what have we seen in these early days? So mostly we've seen applications focused on a supervised classification task. So someone or a team trying to predict a probability of an event, a healthcare event, a disease, and trying to optimize mostly predictive performance. So for the most part, we're talking about prediction, which is a very specific data science task. And so that's important to recognize. There are other applications, which I'll mention. And why have they been applied and what have we been learning? Well, certainly some of the machine learning methods are more flexible. It can require fewer assumptions. You can get at more complex underlying data structures, which sometimes we need to make assumptions for when applying other methods, which can result in improved performance. Not always. It's the right tool for the right problem, and sometimes it works really well, and sometimes we see that our existing tools work well also, and that's totally fine. It's not a competition. It's about finding the right tool for the right problem. And then lastly, I'll say that we're starting to see some unsupervised application tasks, mostly related to identifying heterogeneity in patient populations or segmentation, which I think is a really exciting area and one of the best uses of some of these data science methods. So reflections on some of the applications that we've learned. First of all, we know that in these health administrative databases, the patient timeline is complex. There's things happening, people coming in and out. And so one approach we found very helpful is using the sliding window approach, where you can actually aggregate all the information happening during the observation window and have it move over time. So the dynamic nature of the data and making use of the dynamic nature of the data definitely adds some complexity. It adds some computational resources, which Mohammed spoke about, but also allows us to extract more insights from the data. One thing I also want to mention for context is we're working with these large existing databases, and people talk a lot about sort of developing a prediction model and then going to make sure that it helps the patient at the bedside. And we heard about that example just in the previous talk. When we have large population health databases, we're not necessarily taking that algorithm out and putting it back into the system for an individual patient. interaction. And if we want to be doing that, we have a lot to work through, right, in terms of how data flows in and out of a secure infrastructure. So I think that's something we should talk about. But we try to emphasize the population and system applications. Anytime you want to make an improvement or improve decision for an individual patient, we know that there are individual patient factors, there's clinician factors, but there's also system factors. And extracting this information and applying it at the system level can actually make a difference. So two examples here. One with COVID-19, we know what influences risk of hospitalization at the individual patient level. We had mostly decision and rules around, well, this age, this comorbidity potentially could be prioritized for vaccination. And we found if you actually use all that rich information in a very flexible, dynamic way in the health administrative data, you can actually prioritize more effectively and actually be able to target more precisely. And so these are the kind of health system applications. We have another example here predicting ambulatory care sensitive conditions at the population level. We know that if we want to target system resources to avoid unavoidable hospitalizations, to do that, there are system levels and there are individual factor levels. So these kind of algorithms that we're generating are really drawing attention to the system issues. I think for the future, we want to get at some of the individual clinical risk algorithms that we're generating at the hospital level. And if we can put these together, then I think we're really talking about change and impact. One thing I did want to mention, and this is something that I think is an opportunity and is not consistently done systematically across a lot of prediction applications, is the importance of subgroup assessment. And this is something that Doug, who you'll hear from next, really drilled into me very, very early in my training. How important it is not just to look at overall model performance, but across subgroups in the population. And this relates to a lot of the concerns we have about applying data science and algorithms at the population level. The big one being the very real concern of propagating biases that we know exist in our data. If we don't understand performance across important subgroups in the population, we could be promoting biases that exist in the data and also resulting in suboptimal decisions for certain subgroups. So this, I think, is an area of opportunity. We're really focused on overall performance. That's a draw for a lot of academic applications, but really looking at subgroup performance, especially for populations that matter most to us for reducing health inequities. So where do we have to go? Where can we talk about going forward, and where I hope we'll have more discussion? So the first piece that I want to emphasize is something that I think is different. I mean, this has always been the case that I think complex problems are best solved in teams with multiple perspectives. But when it comes to applying data science applications to these large population health administrative databases, you really need different expertise. And none of the projects that have been successful would have worked had we been limited in who could participate in these projects. We need, obviously, the technical expertise in these methods. We need expertise on infrastructure and computing to even get these models to run. We need the clinical expertise and the experts in the data to ensure that there's no misinterpretation of how the data can be used and what the data elements mean. That's always been the case, but it's even more important, especially if we're having new disciplines approach the problem. And data scientists work in teams. It's a team sport always. There's multiple coding, there's multiple coders on an individual project at all times. That's sort of the practice. And so it might mean changing the way we think about projects and how we enable that team-based participation. Interpretability, explainability, and transparency are areas we have a lot of work to do in. So first of all, these are different terms and they mean different things. And I hear them blended together all the time. We have interpretability in terms of how you can interpret factors that are contributing to a model. And people focus a lot on that. I actually don't think it's the most important. I think transparency and reproducibility and validity are the most important. But then there's a lot of people talk about the concerns in this space, and explainability, again, something different. It's about understanding what's contributing to the algorithmic decisions in the model. There are some really innovative methods in this space, graphical techniques, really creative ways to explain what's going on in a model that really have to change, because now we're talking about different types of models, more complexity. We can't just look at a beta coefficient and interpret it anymore. And in fact, lots of people that applied models, 30 and 40 years ago couldn't exactly interpret a beta coefficient either. That's not the bar. The bar is about making sure we're transparent on how models are being developed, that we have a strong and rigorous framework for validity. Once we know that's been achieved, we know that we can have confidence in the models doing what it said it's supposed to be doing. Of course, there are limits to administrative data, and I would say ICES has done a tremendous job in the last 10 years in particular at really expanding the data holdings, and this is really where we need to go. The more we get at the influences of what affects an individual and their health outcomes, the better we are at being able to comprehensively define risk, assess risk, and actually ensure that that our algorithms are unbiased. And so this is about really stretching out the data that we have access to, going beyond what we're typically used to, from detailed clinical information data all the way up to environmental exposures. That's the kind of spectrum that we really should be aiming for. And by the way, when you do that, the data complexity goes up, which necessitates the need for more complex methods. So these things are all going hand in hand. And then the last one, Mohammed already talked about the importance of ML ops. What I'll say here is how important it is to have that frame going into the problem to begin with. I certainly have approached problems completely different once I have the perspective of how the algorithm is going to be used. Collaborating with human factors teams and understanding, how that algorithm is going to look in the real world when it's going to be applied really makes a big difference. And then understanding that it's not a one-hit deal. We make a model and it absolutely will change. There's data set shift, there's interventions that we're deploying at all times, the health system's evolving right before us, pandemics happen, models continually need to be updated. And so that frame of a continuous learning, continuous updating of models is something that I think is a bit of a shift. So that is it for me. I'll just say, speaking of teams, all the work I talked about today was a collaboration of many, many individuals across disciplines, and I wanted to acknowledge them. Thank you.
Thank you, Laura. That was terrific. And I'm definitely going to be circling back to you about data quality and transparency in the discussion. I think that's something that applies to your example in the health administrative data, but also in what Mohammed was talking about with the clinical data. So our last speaker in this series is Doug Manuel. Doug, will turn the system over to you.
Okay, I might try to show a website too. We'll see if this is going to work. Thanks, everyone. I'm hoping this is going to build off what Mohammed and Laura were saying. One of the things I worry about is Mohammed's got this great algorithm, which I now want to see more about, and he'll send it up to us in the Ottawa hospital and we'll deploy it. And then, a couple months later, we find out that Mohammed coded, males 1 and females 0, and we coded males 0 and females 1, and we didn't know. And it gets just so complex to be able to know at that level what's happening with our projects. And so I think one thing is what I'm talking about, I want to introduce is the idea of open science, collaborating together on projects. Data, it's no longer data housed at ICES, it's data housed at ICES and OHDPQ, and same data at Stats Canada. And we want to collaborate around the world with people that have similar data to ours, but it's also a little bit different. So I'm going to get into the weeds a bit here. Let's see. Yeah, so I just want to have folks aware that there's just this really large increase in tools that we can use to examine and collaborate across institutes and collaborators for data that we all are using, and just walk through one example. So I want to get into the weeds a bit and get people familiar who aren't about what some of these tools look like. So in this discussion, whenever I say we or us, you can just transpose it to all of us, working together, whether that's academic institutes like ICES and Public Health Ontario, the government, federal, provincial, Kai Highs, and others, multiple data platforms. Businesses are the leader in creating a lot of this infrastructure that we're using, and they are collaborators. So I'm not going to go into the slide right now, maybe come back to the end, but it's very difficult to navigate. There's a lot of great tools that are coming. Here's some of my favorite examples. Odyssey, Maelstrom is in the bottom right there in Quebec. Cnodes and ICES has been involved with Cnodes quite a bit, and of course the Health Data Research Network. What I want to talk about is a student, Kitty Chan, and she was an undergrad student that came at the beginning of the pandemic and wanted to do a project, her thesis, her undergraduate thesis project with me. I usually say no to undergrads because our data is getting so complex, even to get going onto our systems. It's just too long. And then the data systems are getting too complex. We had been developing something using some of these tools, and I thought, maybe it's going to work for Kitty. And so she started, and her project was on using the Canadian Community Health Survey and using surveys across time, over 1 million people and almost a dozen surveys, which every survey is slightly different. And so, you have body mass index. One survey might exclude people less than age 16, the other around single digits, the other excludes pregnant people. So to harmonize one variable across that is a huge amount of work, and to do it across dozens that we're now using in our studies is massive. And so how can we, and that's just all of our data everywhere. It's all slightly different, and to harmonize it and to use across centers is a lot of effort. And that previous slide shows some of those tools. So we use some of these tools just to create what we call CCHS flow, and it just harmonized across those. And Kitty went away. We decided that she would do a study on cardiovascular disease at the population level in Canada, focusing on immigrants. And we got her, in one meeting, we got her organized and her topic. And then she went away, got her the data, it's open data. And she started her study, came back a week later, and she was going to give a stab at trying to get her data set across all these data sets. She came back and she had it done. And I said, did you have any problems? And she goes, no. And did it take you long? No, just a couple hours. And this is an undergrad that hasn't really programmed yet and hasn't used these large data. And it was almost like she was just, no problems. And she didn't realize, I think, that would have taken her, 8 weeks, 12 weeks, 16 weeks. Our projects, 80, 90% of the time is harmonized. It was just this sort of almost this innocence that this was just the way that people do it. And so that made me really kind of feel that we might be onto something. Now, Kitty has now contributed to that platform, and other people are benefiting from her as well. And you can see down here, this is what it looks like. And I'm going to try to do the live screening here now. This is it on the website, right? This is all created in R, and you don't have to know how to, the website including, it has 400 downloads a month. And a lot of this is students and trainees as well. And it's all completely open. So an example would be that, say you have, actually, I thought I have it here, I'll find it. You have, say you're wondering about depression. Can we do depression across all these different data? And you could see if anyone has looked at that. I'm going to just type in depression. I thought I had it open already. I don't. Here's a new variable request for depression. And I click on here and I say, oh yeah, Yelric here was wondering whether people have harmonized this, and he has some suggestions. And then there's a discussion. I chime in here. Yelric's on the team, and I give some more comments. And then further down here, Zhang Li 1234. That's Zhang Li Wang, who's one of the leaders of using CCHS for depression. He's in Dalhousie. And then Ian Coleman he's also one of the leaders using CCHS for depression. Ian here on September 9th, he doesn't use GitHub where this is, but he emailed and I put that in here. And then it was put in, and now people can harmonize depression across this data set. It's all open. It's open conversation. If people don't like it, they can leave a comment. If they have a question, they can leave a comment. And so this is people around the field now contributing and working together to harmonize this really important data set for Canadians. And just that kind of example of how people are working together in an open environment with these new tools to speed up the process. So folks like Kitty can compress her study down from 80, 90% of the time down to maybe 5 or 10% of the time in terms of data harmonization. If we create an algorithm on this now, and send it to Mohammed can harmonize his data into this using the same format and feel more confident that that it's going to work as intended. So let me go back to the slide. That symptom depression I walked through. This is what it looked like, what Kitty did. She had in this system, it has just a CSV file, and she goes through and can see what variables are available already harmonized, and she can pick what she wants. And it has the final variable on the left-hand side and the starting variables, on the left-hand side, the starting variables on the right-hand side. And it can you can put a new database in on the right-hand side and it will harmonize it. Open programs like R and Python are terrible at doing labels, but that's okay because you have labels in here that will automatically be put in. Roles, and there's other infrastructure for that. This is how, now you have this code, you've harmonized it, but can you take your code from one place to another? And so many of you who are programmers are starting to use and love configuration files probably as much as we do. And to go back for the configuration files, for how we use it within this package, is that you, again, just link to the same databases that were in that, identify that. You have your name of the database on your environment, and it harmonizes that name of the database for a common one. And so literally now, because CCHS data is in ICES, it is in different institutes, it's in StatsCan, it's in different file servers and places. I can literally now go to take our code that we created in the open environment, go into the closed environment and just type config ICS or config StatsCan and run the code, and it will run correctly because the data is being harmonized to a common data format. And so, so this is just sort of a working example of the sort of tool sets and how people are working in this. Going back to the tool set, these are all various versions of this, where Maelstrom focuses on surveys. They have now 1.5 million different survey variables. Odyssey focuses more on hospital and clinical data. And CNodes and Health Data Research Network focus on administrative data. So it's difficult to navigate these, but I hope this was just a bit of an insight into how people are working in a more collaborative environment. And I'll stop there.
Thanks, Doug. So we've gone from sort of the population level through to the hospital level, down into actually thinking about how to implement some of these shared approaches and continuous learnings around how to use the data. I'm going to kick us off with a couple of questions. And I think what I'll do is I'll direct the questions to individuals, and then the whole panel can respond if they have additional insights or things they'd like to share. Just a reminder to everybody who's watching to use the question and answer tab, which I think is to the right of the video screen. So if you pop your questions in there, they'll get relayed to us here. So my first question is for you, Mohammed, and thinking a little bit about the success of your hospital-based monitoring project. And I think my question here is going to permeate across all three speakers. which has to do with thinking about if you're reporting hourly, do you also have to be making sure that good data are being recorded hourly? Or how is that process automated in terms of thinking of how that fits into your system? So, Laura talked about sliding windows in the health administrative data and understanding the process. That can be months or days or years in administrative data, but you're talking about hours within the hospital. Are things really, are the data pictures really changing that quickly? And are there some lessons that need to get learned there?
Yeah, great question. So you can imagine having data extraction from source systems. I mean, we actually have some algorithms that run every few minutes. So the hourly, fine, we'll use that as an example. But grabbing data from source systems, going through an ETL process where you clean that data in close to real time, feeding that into an algorithm, the algorithm calculating doing the estimates around probability and risk and such, then putting it as a low, medium, high risk categorization, feeding it back to clinicians through a paging system. That all happens very, very quickly. And so you have to set up the data pipelines and the infrastructure to enable that. And some people will say, okay, that's great. It's quite a bit of work. I would say, I mean, I think we've done okay, but we're nowhere near, for example, self-driving cars. Some of the technology there where they're doing processing in milliseconds. Around complex video data and LiDAR, sonar, radar, all that sort of stuff, right? So I think the technology is definitely there to enable this and much more. So I would say real time is something that is technologically very, very possible. It's more about getting the process and the infrastructure right.
So maybe just continuing, I have another related question related to innovation and how quickly health systems adapt. So even if the technology is there, how's it? But maybe before I ask about that, maybe Laura and Doug, I don't know if you have anything in terms of data timeliness and understanding sort of quality and flow. Laura, certainly quality was a focus on what you were talking about.
Yeah. I mean, I think Mohammed touched on it. I think what we need to do is invest a lot more time in the data pipeline and building in automated quality. I think what historically has happened in a sort of investigator-driven model is that an investigator interrogates a question and then they really clean that data up to the quality that we can do what we want to it. But it sort of happens in an ad hoc way and it depends on the question and the project. And we really need to take a system approach and really make sure that invest in it. But in academia, we don't get a lot of credit for that type of work. So it's one of the reasons why it hasn't happened. It's not because people don't want to do it, but there's not the incentive. So how do we build in the incentive for that really strong data quality cleaning work and the funding and the infrastructure for it? And once that happens, you can see it's going to percolate through and improve the quality of everything we do, from basic descriptive statistics that are used for surveillance all the way up to complex algorithms.
Yeah, I think that's a fair point. And having taught about health administrative data with you, we certainly spend a lot of time talking about the pitfalls with the data and how students need to understand how they're collected. So some things can be cleaned and quality can be optimized. Other things are a function of the incentives in the system as well. And I think that can pose real challenges. Doug, did you have anything?
Yeah, I think so. I have a couple comments. One is I don't talk to Mohammed and Laura nearly often enough, but it's interesting because we use a lot of the same language, data pipelines and DevOps pipelines. And I use the word data pipeline a lot, and I notice they both use that term, and I would use that term as well. And the pipeline is different now than it used to be. You're not having a PDF and handing it to your buddy. You're not an ICES analyst and then handing a Word document to another ICES analyst. That's just a different way of doing work now. You can't analyze and use large complex data. It doesn't scale. So we have to have a different system, which we often call these sort of pipelines. I think, like building on what Mohammed said, though, I think that we have some challenges that Tesla automation, self-driving cars doesn't have. We have our like I say that MasterCard doesn't have to validate fraud detection for Visa. They do it for themselves. And I think that we have hundreds of hospitals, tens of thousands of hospitals around the world. And the data is different, and the processes are different. So again, like if Mohammed is doing something that I want to implement up in Ottawa, that the automobile cars don't care about, they don't have that problem. And so I think that we have some challenges that others don't. And I'll just stop there. But the pipeline and how to do projects faster and better than we did before when they were way simpler.
Thanks, Doug. And that actually sets up the next question nicely. All three of you have alternated between wearing your researcher hat and then wearing the application hat, whether that be to populations or to clinical settings. But how do you think about all of this innovation and change in healthcare systems that can be really slow? So what should health system stakeholders be thinking of? What should we as researchers be thinking about in terms of timelines and time horizons for widespread implementation of these things? Michael in his early remarks talked about 30 years of ICES. A lot of what we see is individual pieces happening here. How do we get to that vision of systems?
Maybe I can kind of start off. I think the ultimate, in my mind, would be a real-time data system that would be at the provincial level, ideally national level, and if I would dream, the international level. But I think real-time data systems, and it's not like they don't exist, right? Well, we have Connecting Ontario that clinicians use for patient management on a day-to-day basis. The legislation doesn't allow for secondary use. That's my understanding at this time. Could that be changed? I think so. So again, I go back to, it's probably not so much the technology, but more the people, the vision, the drive to actually expand and enable us to be better. The other thing I would add too is this this thought around openness. Like I really enjoyed Doug's talk around, like a lot of these technologies that are out there, you can bring data sources together from different places. The TCARM part that I didn't go through in my talk was around, we set up a whole data platform on Google Cloud. And the reason why we did that is purely on GCP is because we knew that 10 years down the road, if we have researchers from all around the world, we're going to run into compute issues. And we don't want to keep buying servers on a local environment. And how do you scale? I mean, I think you have to go to environments that have virtually unlimited storage and virtually unlimited compute. But having that meld of vision to say, if we go to real-time data for the entire province, do we have capacity? Does it make sense for us to have local infrastructure? I think you inevitably have to go to some sort of a cloud-based solution. What is that right solution? It's that sort of thinking that I think we need.
So maybe for both you and Laura on that point are, how do you apply things in regions or hospitals that are different from each other? Like, it's nice to talk about the provincial pipeline and how to do that, but how do you make sure you're accounting for some of the important differences? I don't know, maybe Laura, if you've got a little bit to add, and then we can come back to Mohammed and Doug.
Sure. I mean, I think first and foremost, you need to validate, right? Like, validation needs to be part of this process at all times. And so oftentimes when we run models and we look at it locally and it's not working, then we ask why, and we go back and we fix it. I think that's a frame that people are uncomfortable with in academia, because their idea is that you have a very polished research question, it works, and you publish it. Whereas this tinkering notion, I think, should be the norm. The idea that you will have to make adaptations for things that differ contextually, and actually probably bring in data or information that might differ contextually. And then it's just about how do you bring it in a reproducible way that's very transparent. And so I don't get sort of miffed by when things don't work in other settings. I often don't expect them to, and if they do, I'm shocked. And then and try and investigate why. And often when you put that in over time, they improve. So I think just this notion of constantly need to recalibrate, adjust. I mean, that's what a learning health system is too. To your earlier question, that's how I think we shift the mindset to this kind of idea that we're using data to improve. And then once we improve, we go back, and then we're going to have to improve again. That's kind of the frame I would go at it.
Doug, anything to add on this point?
You know, again, like a data pipeline, learning health system, these are words that we're talking about a lot more now. People, process, and technology. A learning health system isn't about necessarily the data flow. It's about how people work together, and understanding the time is people as well, and the processes for that, and setting up, Laura, we're getting ready to deploy end of life algorithms in the community level. And before we do that, we're trying to set up to make sure that we can have that data to assess calibration. Like you said, we know the calibration will drift or be off. That's fine, as long as we have a system in place with people and process and technology to be able to do that before we deploy. Right now, the Framingham risk algorithm that we still use in Canada daily, or the other algorithms we use in Canada, they are badly calibrated. They're like twofold off. We're telling people they're twice the risk of heart disease. We're putting them on drugs when we know they're off. This is an industry, $1 billion industry. If we can't assess calibration for heart disease risk, it feels we got a problem. UK, Q risk, they recalibrate that every year. New Zealand, more sheep than people, they've done that at a national level, and have been able to calibrate for MALRI and social demographics. So we're using, Framingham risk algorithm, we're using an algorithm that's 25 years old. We know it's badly off, and we don't have processes in place to assess that for equity, and we know it's wrong. We know it's off. So I think, I think there's challenges and opportunities, but we use the same learning health system, and some of these same terms. It's really fun to be on a panel with Laura and Mohammed.
Maybe I could just probe you, because you said the word equity, and it came up in Laura's talk in terms of thinking about different subgroups and risks. How do we think about that in these open pipelines? We know that there are missing dimensions in some of the data that we use at ICES. We also know that thinking about how to assess some of those dimensions involves the communities that we want to talk about, and thinking about what's important. So how do we think through those issues if we can't measure some of the things that we know are important?
I'll start. So I think sometimes when you start these projects, you have to accept the fact that you're not going to be able to proceed because the critical information just is not there. And so sometimes I like to say slow then fast. So talk to who's going to be using this, talk to communities that are most affected, figure out where this will work. And then once you figured it out, you can move fast, but don't sort of go past that step. And it can be frustrating, I know, because people want to jump into analysis, but there's no point in getting there if you know you're not going to be able to proceed. That being said, there are now, and this is a growing field, this is one of the more exciting fields, I would say in the last 2 years, there are actually some best practices being built on how to assess fairness and bias in algorithms. One of them, again, doing subgroup approaches. A lot of it has to do with community engagement and getting the right data to begin with. So that also needs to happen. And so this is something that is going to be one of the steps that I think get integrated in. Right now is kind of spotty all over the place. What I tell people, at the very minimum, you have to assess it, acknowledge it, address it and correct it if you can. And that's the ideal. Sometimes you can only do 2 or 3 of those steps. Everybody should be at least making an attempt to assess how important of a problem it is in their particular application.
Okay. Mohammed or Doug, any further comments on that point? I've got some other questions I can move on to from the crowd as well.
Yeah, Sorry, go ahead, Doug, if you want to.
No, happy to move on. No, I don't have anything else to add.
At my end, I totally agree with Laura. Go slow and steady. I mean, we've seen the horror stories actually from the US, for example, where they have algorithms and HMOs that have been deployed that amplify the racial bias, where Black patients are treated, let's say, suboptimally relative to other races. And do you go in full force and amplify that magnitude, or do you actually go slow and say, we don't have this data, we're going to collect some of it, we're going to test the algorithm in it, make sure it's doing what we think it is, and then we'll scale it? That's probably a safer approach.
Okay, there's a question that circles back to some of the data pipeline issues that you all were talking about. So does developing better data federation capacity enable this vision for the pipelines you guys were thinking about, as opposed to just feeding data into repositories regardless of the timeliness of the data flow? Any thoughts on that? Mohammed, you're up on the screen at the moment, but
Sure. Yeah, I've got mixed views on federated learning, to be honest. We're actually involved in a fairly substantial international federated learning project now. I think it has great potential for research. If you want to go beyond research and you want to get into deployment and more applied stuff, I just don't see it. And maybe I'm missing something and it'll get there. But one of the issues with federated learning is if you have local environments, for example, well, you need to be able to deploy things locally, and you have to have those technical skill sets and the data there, and then you actually send results up to a central location. So it does require technical expertise. It does require some infrastructure. I think it does get around a lot of the issues that people raise in terms of sharing data and privacy and that sort of stuff. So I think it has tremendous potential there, and that's the way I think we're going to move forward. But again, I would say for other purposes, it's probably not an ideal approach.
Yeah, and I'll just quickly add, I'm really excited about federated learning as well, but it can't be the only approach. Sometimes I worry that people are saying, okay, we'll just do federated, and then that helps them not face the really hard issues of the fact that we do have to have some interoperability and data pipeline. So I total agreement, it needs to be both, and it can't be one or the other. The other thing I'll say about federated learning, which I've realized, is the context, especially international projects, is really important, and they don't make their way in. So things like policies and laws and cultural norms, if we're doing federated learning, those variables have to come with it. Otherwise, it can be very difficult to use the data. We can't sort of pretend that we operate. This is just some work that we've been looking at in Europe, that we operate under the same social systems. We absolutely do not. And if you're looking at things like health equity or population health outcomes, if you don't consider those, it doesn't actually make a lot of sense. So I think that we need to do a better job on federated learning at bringing in some of those factors as well.
okay.
I think I would agree. One size doesn't fit all. But federated learning is definitely on my watch list. But I think we're talking about different things there too. About I think we need to work on larger projects, international projects, collaborative projects. I think the biggest. I think saw a little ad for Bill Clinton. Like most important things you don't do by yourself. And I think the most important global challenges, I think we need to work across it. So federation is on my watch list. I think the highest on my watch list right now is synthetic data. I'd be interested in hearing for others as well. But I think data access is still a really big challenge. And if I think we might be working more and more on synthetic data over the next, and it may be the dominant way that we're going to be working on data. So, you get data that looks essentially identical or very similar to the original data, but you can move it around and then analyze it. And then if you need to, then you can analyze it on the original data in your secure environment or other things. But so I think that would be another option. Like one size doesn't fit all, but instead of moving your analysis to the moving your analysis out, you can move it. You can try to move the data. Continue to try to move the data out as well.
I was going to ask you to define synthetic data, Doug, but I think you did at the end of your conversation there. Who has the responsibility for generating the synthetic data, right? Like if you're already challenged in terms of sharing or collaborating or doing other things, just not just add another layer of complexity. Or yeah, again, I guess it jumps back and forth a little bit between you got your researcher hat versus some of the other hats that are doing this type of work.
Yeah, I think at the Ottawa Hospital, we're deploying synthetic data, and StatsCan, CaiHi, everyone's working on it as well. And so I think it's the data custom. Like instead of like, it would be like ICES. You know, instead of making your data available to others or cutting data for others, you're doing the same process, but then you're taking it and you're making it synthetic, and so that it can be moved around more easily. And so in Ottawa, it's a way, like we've heard from the community that, you know, like I call it Canada, but you know, our sort of industrial or our computational folks, like they'd like to be able to work with the data more, develop more commercial applications or not-for-profit applications for others. And again, the pipeline to get the data accessible for them and the privacy concerns around that is the people in the processes, you know, the RABs and others, you know, I think we should be able to get projects up that go in an ICS in a day, you know, and it's not a day right now. You know, with Kitty, we could get her going right away because StatsCan changed the CCHS license to an open license. And we put that survey in that package that anyone can test. We don't put the whole thing, but we have links to it, but we put samples of it so that people can get up and coding right away using the package. And they don't have to, as soon as you do that, you make it, that's when you have 400 people a month accessing. And synthetic data would be a way of doing that, you know, putting synthetic data out there so that people can start analyzing the data and have results that should be real results. It's just, I think, again, one size doesn't fit all, you know, but I think, like I said, it's pretty high on my watch list. It's on the watch list of a lot of institutions as well.
That watch list is growing in the corner.
Yeah, I know. It's very long watch list.
I'm looking at the time. I think we've got about four minutes left. I think there's a question from the audience that shifts the thinking back to the bedside a little bit. So the question says, something that's always been a challenge for data collection and quality has been application and uses of the data at point of care. So this may be heading towards you, Mohammed, a little bit. Algorithms have historically had variable predictability and sometimes not better than clinical decision making. So how do you sell this level of commitment to data quality and collection, and to whom?
And maybe I can take a crack at that. You do your homework. So for example, with the algorithm that I'd shown around predicting death in ICU transfer, we actually spent a few months on the floors asking doctors, nurses, and residents what their predictions were. And it was kind of unfair because, you know, they have time to think about it and you normally don't when you're in a busy clinical practice. But we had over 3,000 clinician predictions, and we're going to be publishing it very soon, where we were able to show that the algorithm, in conjunction with clinician judgment, considerably outperformed clinician judgment alone. Without that level of data or support, it's tough, right? Because clinicians will say, how do I know that this is going to help me? Maybe I'm better than the algorithm. So if you're able to show it in a much more rigorous way, you get buy-in much easier.
Laura, Doug, anything to add to that point?
No, I mean, one thing would be, you know, we're talking a lot about algorithms. I don't sure why, because, you know, there's so many different uses of the data. And then as well, like, I think of the algorithm as like this tiny sliver of the effort, you know, data cleaning, but also implementation. And so, you know, talk about algorithms, say like Ottawa anchor rules, 2 features, perfect performance. And the folks here in Ottawa know that the clinicians will do everything possible not to use it. You know, they'll want the X-ray. They'll wheel, like, even when you're doing a study, you know, they'll wheel the patient around the the study the enrollment person and get them down to the X-ray department. And that it's a perfectly performing algorithm that you can see with 2 feet. It takes you half a second to do. And so implementation science, behavioral science, learning health system are much more important than an algorithm.
So you're circling back to Laura's point about the multidisciplinary nature of some of this work and the teams and everyone who needs to be thinking.
And more time consuming than developing an algorithm.
Yeah.
More
Okay.
effort.
Well, I think I'll end the plenary session here. Thank you all so much. I think you gave us lots to think about. Glad that there were so many commonalities in terms of how you were thinking about things in different parts of the system. So really appreciate you guys taking the time to come and chat with us today. At this point, I'll turn it back over to Michael Schull, who will introduce the next plenary session. So thank you all very much. Give you a round of applause because you can't see the portal.
Yes, thank you, Sue, and thanks to the panelists. That was a terrific start to the research forum, and definitely very future oriented, which is exactly what we're trying to focus on today. So I'm excited to introduce the next panel and the moderator for the next panel. The next panel number 2 is entitled "The Promise of Cross-Sectoral Data for Addressing Health Equity." And our moderator is Dr. Astrid Guttmann. She is the Chief Science Officer and a Senior Scientist at ICES. She's a clinician at Sick Kids in Toronto and a professor in the Department of Pediatrics at the University of Toronto, and she'll be moderating the panel. So over to you, Astrid.
Thank you very much, Michael, and delighted to be here. Before I introduce our distinguished panel, I'll just give a little bit of context for this panel, building really on what Michael spoke about in his introductory remarks. So one of the most important directions that we've set at ICES is to use data to address the social and structural determinants of health and enable policy relevant research to address health inequities. And one very important way to achieve this is through the integration of population-based data from across a number of sectors outside of health and healthcare, such as social services and education, amongst other. And while much of our current work is focused on the healthcare system, of course, we understand that health needs, the outcomes of healthcare are determined by a complex array of these important social and structural determinants of health, and by investments and services in other sectors. And I would argue even that some of the most important outcomes of what we do in the healthcare system are best measured with data from other sectors. So for instance, why do we not evaluate the impact of neonatal clinical care services, mental health care services, by how children and youth do in school, as an example? The second important context is that a number of provinces have enabled the linkage of provincial data from across ministries through legislation. And there's been longstanding, and actually Manitoba would probably be the prime example, and we'll be hearing about that in the panel. And there's been longstanding interest in Ontario to do the same. And recent legislation that has passed to allow these kinds of linkages to occur within government, and indications of further legislation to come that will allow organizations such as ICES to do the same for purposes of research and evaluation. And so with that sort of stage setting, I'm really delighted to introduce our panelists. They will not be doing formal presentations. This is really a conversation. We have a few questions that we'll be discussing initially, but we'll definitely leave time for questions from the audience. So please put those in the chat. If there's one panelist in particular that you'd like the question directed to, please just put that in, and we'll try to cover as many audience questions as possible. So delighted to introduce our 4 panelists. So Aki Tefera is the Assistant Deputy Minister of the Business Intelligence and Practice Division with the Ontario Ministry of Children, Community and Social Services. In that role, he leads provincial scale policy research and evaluation projects in collaboration with people in academia, but also other ministries. And that includes overseeing partnerships both with ICES scientists, but also with ICES around pilot projects that have been conducted related to health and mental health outcomes of recipients of social services. Marni Brownell is a professor of community health sciences at the University of Manitoba. She's a senior scientist and the associate director of our sister organization, the Manitoba Center for Health Policy. She leads an incredibly impactful program of research focused on child health and well-being using the kinds of data we want to talk about, linked data from a wide array of sectors, including education, social services, child welfare, criminal justice system, and of course, health, working in partnership with community organizations, as well as very closely with policymakers. Brenda Parris is a social services professional with over 20 years of senior management experience in multi-service organizations, settlement, and other immigration programs and services for seniors and persons with disability. She's also a member, we're very fortunate to have her as a member of the ICES Public Advisory Council, where she's been a really outspoken advocate for ICES to continue to do more to address social determinants of health and inequities. And finally, Arjumand Siddiqi is a professor and the division head of epidemiology at the Dalla Lana School of Public Health at the University of Toronto. She's the Canada Research Chair in Population Health Equity and an internationally renowned social epidemiologist whose work focuses on understanding how social policies and other societal conditions influence health inequalities. We're also very fortunate that she's a member of the ICES External Scientific Advisory Committee. So with that, we'll start the discussion. Aki, I thought I would start with you. Maybe you can speak from a policymaker perspective and just tell us a little bit about the kinds of policy challenges and evaluation needs that you think could be addressed by linked cross-sectoral data.
Oh, thanks very much. Thanks, Astrid, for the question. And can you hear me? Can you hear my voice?
Yes.
That's great. Okay. And thanks for having us here today. This is really a timely conversation that we're having. A lot of policy issues and policy problems that we struggle with every day in government and from my vantage point. We talk about structural and social determinants of health, and we been really any policy expert can intuitively talks about that. Just generally in government, we talk about social determinant health and some of the social and health connections and so on. But one of the main challenge we have is how do we really translate that into a real policy tool? I mean, I'm talking about big P policy tool as a systems policy concept and evidence to support that conversation at a kind of policy decision-making level. That's one area. And then I'll talk a little bit about that. And then we also asked the question around how can we really bring this to bear in terms of investment decisions and choice that the government does, and how do we really reflect the various impacts of government decisions, investment decisions in the social service sector, for example, or in the school system, or in the justice system for that matter, and then its impact on health equity, health outcomes, and so on. And finally, in the third point that I'll bring up is around the service system design itself. So I'm just kind of trying to touch three areas in government that I think there's a lot of value and contribution from the kind of conversation we're having today. Policy, B2P or small program policy space around investment decisions, since that's basically where the money goes, and around the service system design itself, more importantly, locally. So just quickly on the policy tool, I think we've seen a lot in recent months. I mean, the pandemic has been really very clear around equity issues, structural equity issues that we have. It has actually surfaced the fundamental structural issues around the population level, any neighborhood level equity issues that we have. We look at a number of congregate living, precarious jobs, inadequacy in income, and other things that have exposed some of the health outcomes that we saw in the pandemic, and then just more broadly. we know that we have some deeper systemic and pervasive issues structurally. How do we really address that? How do we start chipping out those issues? And then how do we really change the policy discourse, just only from a sector or vertical health or social or education or other public sector into more holistic social determinants, health and the structural discussions, as you say. We generally know that as we move forward, especially as we come out of the pandemic and into the endemic, hopefully discussions, there are a lot of questions I would be asking. So what does that mean? And how do we really prepare ourselves, both at a broader public policy level, investment decisions, as well as how do we really design services locally to make sure that the kind of issues that we witnessed and were surfaced through the pandemic do not repeat themselves. And how do we respond to some of those very difficult policy questions? So that's one thing. And the other one is the investment decisions. For me, I think that is critical. Generally, in government, we rarely talk about downstream, upstream, and sidestream effects in a meaningful way. We talk about them qualitatively. We say, X, Y, Z happens, and then therefore people will be better off and so on. But that doesn't really lend itself at the treasury point to a good investment discussions and decisions. I mean, the traditional discussion, take the money out of the health system and front load it or front invest it so that, the downstream impacts of those investments could be better. We don't have good tools, good data to demonstrate that and kind of just basically support government decision makers in that area. It's a lot of interest, a lot of questions, and rarely an answer. At best, what we do is morning after analysis of an investment, and unanswerable, and we invested so much. Many jurisdictions have gone further away in terms of kind of quick, really understanding the economic impacts and the social and health impacts of government investment decisions and policy choices. We're not there. At best, we do comparative static analysis. We don't understand the entire dynamics that happens between these different streams of health, social, and economic interventions that we have out there. So I think, to me, the kind of conversation we're having today are really, really important. And then finally, and most importantly, I think about service system design at a local level. And in those cases, I think we know, at least intuitively, and from various federated evidences, I think I heard that point earlier, at a local level, early intervention works, front loading investments soon enough and addressing both our health and social spaces so that people can become better and then improve their well-being helps. But we don't have good evidence in terms of scaling it up. How do we really scale up to those small evidences? And to me, I think all these pieces tie up to that need around having a very strong data infrastructure that we need to build in our organization. And we've gone a long way. You mentioned it, Astrid, that we've started building that data infrastructure internally, and government internal is always government internal. So what we've been really thinking about is how do we really empower organizations like ICES? We've got a lot of comparative advantage in this, both technically, structurally, and how it's connected to the broader academe. How do we enable that? And I think there's a legislation that's underway. Hopefully that we will get that to light, see it coming out and advance this. I mean, I think, to me, these are like more of the policy questions and the infrastructure discussions. And then as we go forward and challenge ICES and the scientific community, how do we really build these core social determinant and structural determinants questions into our strategy, research strategy, and evidence development strategy? How do we really govern that, and how do we invest in that activity? I think these are the discussions that are healthy to have, so that I think we can support policy decisions, investment decisions, and service design, service delivery decisions. And let me stop here, and maybe I can reflect back on other questions and discussions a little later. Thanks, Astrid.
Yeah, thanks, Aki. And we'll definitely circle back. And it would be really interesting to hear about even like a really specific example, maybe to get us thinking. I'll turn the next question to Marni. Given all the work that you've done throughout your career, again, working with government and, using data from different sectors. Can you give us just an example or two of some like impactful work that you've done leveraging these kinds of cross-sectoral data, and maybe thinking about maybe reflecting a little bit on what the successful elements were of that work that led to the impact?
Sure. Thanks, Astrid, and thanks for inviting me to be part of this panel. It's really great to be here. I think one of the impactful examples, the most impactful example of the power of the cross-sectoral data is actually one of our earliest examples. It's actually been 20 years since MCHP signed agreements with some of the non-health data providers, including departments like education and families. And one of the first research projects we conducted with the linked data was looking at educational outcomes. In this case, it was grade 12 exams and how these were associated with SES. So for the first time, we had education data. We also had, for the first time, individual level income data for some of the most marginalized Manitobans, those families receiving income assistance. And, we put that together also with our population registry. So we were able to also see not only which youth were in school, but the youth who were not in school and should have been. And that was really the first time that we were able to look at it like that. And when we started this project, everybody assumed we would see a gradient in outcomes, but no one really knew the extent of the gradient across socioeconomic status. And the findings were really dramatic, showed incredibly large gaps in outcomes, but importantly, too, it showed a different sort of story depending on how you looked at it. So if we only looked at the education data, which, for years educators have been able to look at, there was a gap, but it wasn't that great. It was, a difference about 75% from the lowest income passing the exams to 95% at the highest income. But when we added that population perspective, when we added the registry data, the population registry, and included the kids who had dropped out of school or who had fallen behind in school, the gap was really, really big. I think it was about 15% of the kids and families on income assistance had actually passed these exams on time compared to 80%. And so the findings really caught people's attention. And so in terms of impact, within a short time after their release, there was a lot of impact. There were initiatives that were implemented, including a joint initiative between the Departments of Education and Families to provide more funding to low-income schools. There were school-based initiatives, homework programs and peer support programs. And the start of summer enrichment camps in inner city areas that are still going today. And, again, talking about impact, eventually the findings contributed to legislation, the passing of the Community Schools Act in Manitoba, which funds cross-sectoral services to support low-income families and boost student achievement in low SES areas. So you asked about, what are the elements that led to impact? And, there are probably dozens, but I've thought about four particularly. One is just the power itself of the population-based perspective that cross-sectoral data provide. As I said, using the education data alone really underestimated the true extent of inequities. And the key was adding that piece about the youth who are no longer showing up in the education data. Really, like when we look at things, who's not using services is as important as who isn't. I think a second important element throughout the research, we worked really closely with the departments providing the data to ensure we had a good understanding of the data and also what the data couldn't tell us, what it could and couldn't do. And this built trust and respect between the researchers and the ministry staff. So when the results came out, they knew that they were credible. There wasn't a questioning of, oh, this can't be the case. They knew how careful we had been in our analysis. I think a third element is getting the word out, whether you call it knowledge mobilization or knowledge translation or knowledge exchange. we shared and discussed these findings so broadly, not just with ministry staff from the data providers who had provided data for the study, but all sorts of different groups, school boards, school conferences, community groups like the Social Planning Council of Winnipeg. I think Randy Francoux, who worked with Norlu Roos and I on this project, went to all the school divisions in Manitoba at some point, sharing these results. And so this was important in terms of making sure the results were understood, but also now it wasn't just MCHP researchers urging government to address inequities, but educators and community organizations, excuse me, and advocacy groups were all pressuring the government with the same message. And then the last thing I'll say in terms of impact and making sure your research has an impact, I think our timing was good. You know, sometimes you get lucky, sometimes the timing is right. I have had plenty of examples of the opposite where, you know, we can have remarkable results, really good evidence, and there's really no political will. But I would, you know, give this advice to ICES as you move into this. As Pat Martins used to say, researchers need a back pocket mindset. So you can't always count on the immediate uptake of your results, but these issues never go away, and inequities are unfortunately not going away. So having the evidence in your back pocket where you can easily retrieve it when the time is right is really important. And I'll stop there.
Yeah, thanks, Marty. I mean, it's, you know, just as you were making those last 2 points, you know, just thinking about, you know, all the data that's coming out now about, you know, the widening inequities in school achievement from other jurisdictions, because we unfortunately don't have very much data here because of, you know, what's all the disruptions during the pandemic, but also, you know, other jurisdictions that are monitoring how many children completely dropped out. To your point about, you know, you actually need to, you know who should be using, you can't just look at who's in the system, but everybody who should be in the system. So those seem very powerful words for, you know, the current situation. So thank you. So I'll pass it next. Maybe would be very interested, Brenda, you know, as a member of our Public Advisory Council, but also from your professional experience, you know, Marni's given us some advice about, you know, as we start to hopefully do more work in this area. What's your advice around, you know, how we engage the public and communities about the use of these linked data from government ministries? And in particular, I wonder a little bit about, you know, what your take would be around, you know, the kind of public concern that there might be around so many different types of data being brought together all in one place.
Sorry, wasn't unmuted. I'll start with the last point, which is the hard point about concern about use of data and suspicion people have. And I think they're better people than myself to comment on some of the technical aspects of that. But I think generally speaking, it's important to have some of that data, no matter what stance you take, whether it's for your own purposes in the community level, or whether it's in institutional level, or whether it's in government level. We've got to start counting, because if you're not counted, you don't count, the old phrase. And what COVID has done is just revealed to the other part of the community the inequities that we knew all along, but we couldn't necessarily prove or demonstrate in ways that have an impact on people. Oh yeah, just another study about poor people, for example. It revealed the frailties in our healthcare system, which every Canadian is proud of and thinks is open and free and accessible. We do not have an accessible healthcare system and haven't had for a while. But we've known that, but other people have not known that. COVID brought that to high relief. And I would start by saying, understand two things: that don't assume the public will share your assumptions about the social good of research, that gathering data is a social good in and itself. nor do they necessarily share some of your values that other things are important. There's a huge level of distrust, not only because of our modern COVID conditions, but you must never assume that people share the same values and trust in institutions that you may have. You may trust your healthcare system, you may trust your hospital system. A whole lot of people don't, okay? When I was working in Scarborough with clients and adult students, very few of them had any regular contact with healthcare systems. Very few of them had a regular family doctor, which is the pivotal person in any healthcare delivery discussion. So the issue of access is in ways that people haven't even begun to understand and address. There is poor people's medicine and there's rich people's medicine in this city and in this country. And I think the sooner we understand that, the better. So my advice is it will take work and some humility to work with organizations that may not think that what you're doing is the best thing off the bat. I think it means you're going to have to develop a skill set of working with community organizations. And I know these things are not readily available in everyone's toolkit. And if you don't know how to do it, get someone who can. I mean, you can use students to do outreach. You can use students to do research as to what relevant organizations you could work with. They're out there. And many of them did rise to the occasion during COVID when other systems, including public health, failed miserably in terms of outreach. Now we have some things in place, but if it hadn't been for the folks in Brampton, who, as you remember, had one of the highest COVID rates, literally going out to the temples and the guaras, they went door to door to get people vaccinated because they knew where people lived. Most healthcare institutions and research bodies wouldn't do that. So really, you need to learn to do outreach, need to identify relevant community organizations. You need to engage in a process, which is timely and time consuming. So you got to build that into your understanding of timing and pace. And understand that some of the questions they may want answered may not be what you want answered or that you can easily answer because of the nature of what data you're gathering. I think any attempts to integrate data from different sources is a good, because you cannot talk about healthcare, you cannot talk about housing, you cannot talk about income issues unless you look at them in the whole, okay? Education being a good one. Education is so dependent on so many other factors in terms of outcomes. So my message would be outreach, contact, understanding relevance, working collaboratively with people. If you don't have these skills, which many people don't, then learn them or get someone else to do it for you. Because in the long run, will give credibility to the work that you do and it will make it usable. It's not all data will be used for purposes of policy and decision making. We know there's other factors that go into that, including politics. But the junk in, junk out. Better you have good data in and get good data analysis and solutions at the other end. And I would just think that this is too important, particularly now that we're finally understanding the need to identify race and ethnicity. It's long past the time when we should have been doing that, and hopefully that will be done in a timely manner going forward. I don't know if that addresses some of the things. I'm happy to hear any questions at the end of how best to do that in your relevant context.
Yeah, thanks, Brenda. I think it'd be interesting to hear from some of the other panelists as well about the piece around building trust, but I'd like to first just pick up on what you were saying about race and ethnicity and maybe turn it over to Arjumand. Arjumand, from your perspective, because I think Brenda sort of highlighted like a huge gap that's been discussed, I think widely about many of our data, that there's not a lot of individual level socio-demographic data, certainly self-reported race and ethnicity being amongst them. So Arjumand, I'm wondering if you maybe can reflect a little bit on some of the important gaps in existing data and the ones that really limit our ability to, even as some of these, service delivery data come together, some of the larger gaps in doing health equity research.
Sure. Yeah. Thanks so much, Astrid. And thanks for having me on the panel. And thanks to my co-panelists. It's really nice to be here. I think Brenda made some really, really important points. And I think the gaps to me are about what data isn't available, but also sort of the premise of collecting it and the premise of what we think is important to know. And so I think, this conversation about race ethnic data is really interesting for me because we weren't having it for a long time. And I think we are now sort of saying this is important to collect and understand. And for me, what's even more important is to figure out what changed, what made us want to collect that. And I think it gives a lot of insight. So I won't speak to sort of what I think are the social and political dynamics of wanting to collect that. But I do think that what's been interesting is a conversation that in the past went something like this. It's actually not that important to know what, racial groups are, sicker, are, more likely to have COVID, more likely to have cardiovascular disease, et cetera, because what really matters is socioeconomics. And so
Class trumps race, yeah.
That's actually even now a very prominent conversation. And it's a little bit like saying we shouldn't care whether women are getting paid less than men in the workplace because it just matters that somebody's getting paid less. And so I think we were obfuscating the fact that particular social groups for very particular political and social reasons are the ones that are most likely to be compromised, disadvantaged, oppressed in various ways, that it's not an accident that you have the distribution that you have. And so that's sort of one kind of lens on this is race is certainly something that I think we need to collect and know about, because I think we need to expose in no uncertain terms that this is happening in a way that documents it publicly. I'm often asked this question, do you think things change when data gets collected? I'm actually not convinced they do, but I still think that knowing what our society is and what it's like and having a public record on this of various kinds, of which data and science contribute one record, is really important. So in my mind, the best data to understand these issues is data that either does one of two things. One is ever present in all the spheres of life that we would want to understand human well-being and human suffering and injustice. And so that means having data always linked to metrics and databases that examine anything to do with opportunity and resources, whether that's health services or education or job opportunities. And if that isn't there, then there should be a readily linkable way to do that. And so, for example, in the US, part of the reason that they have so much information on racial inequity is that race is embedded into almost every record there is. They don't even have to link things because they're everywhere. So your death record, your birth record, your everything has your race tethered to it. And so it makes it really easy to kind of see it. So that's the sort of race issue. The other kind of what data should we have that we don't have, I think comes back to what we know about how social factors operate and what ones are the sort of dominant in shaping our lives. And so factors like race, gender are dominant in shaping our lives because they're the major way we structure power and resources. Part of the way they're expressed is through education and income, but importantly, also wealth. which I think is something that we don't really pay much attention to in health. And we often conflate it with income. But if you look, for example, at the US data on racial inequities in a host of outcomes, including education, including anything you can think of, the main story is actually not even income, it's not education, it's wealth. And wealth is not wealth that people themselves accumulated. It tends to be wealth that was transferred to them by prior generations. And so the major issue in racial inequity, arguably of every kind, is wealth inequity and a sort of generations long history of people in power, of white people being able to accumulate wealth and pass it on, and people who are Black and brown not being able to do that. So in my mind, we can talk about particular indicators that would be valuable, but I think in many ways, what would be most helpful is to know what the backbone is. What is the kind of driving impetus for what we want to know? What is it that we're using as an orientation to the world, and how inequities occur that would actually help us then understand them and hopefully rectify them. And if not rectify them with the data, at least announce to the world what we're doing and what kind of society we are.
Thanks, Arjumand. That's very intriguing. I'm sort of curious whether are there any jurisdictions that do measure some of these more important metrics and use them for policy, like such as, as you're talking about, sort of
it's a great question.
And access to opportunities.
Yeah, so in the US, wealth is also very, very poorly measured, but they have started an initiative to look at racial inequalities in wealth using a combination of existing data and some data collection that has actually gotten a fair bit of traction. There's been conversations about fixing wealth inequality that penetrated up to the, for example, the Democratic primaries and so on. Most candidates had some policy platform that included something about rectifying wealth inequality. So the short answer is not good data really anywhere. I guess the other example is Luxembourg income study that I think at least now has some wealth data, but I don't think it's regularly used for this purpose.
Astrid, could I just add something here? I think that the two great taboos in Canada is talking about income. So no one wants to talk about wealth and class. No one wants to talk about class differences, and race. And because of our Canadian value and myth of who we think we are, Canada and Canadians in general and institutions in particular have not developed the comfort level with talking about race and difference and ethnicity. We tend to obliterate it, don't want to talk about it. We're the great accepting country. So it means you can't even get to the first base of even accepting that it's a valid category of information to have, because we want to deny that it should apply, because we think it's mean and nasty to talk about that. So we got to get over that hump and understand, like gender, we all have mothers and sisters, so we knew how to talk about women and feminism and change. None of us have close family friends who are Black or brown in the Canadian context, right? So we don't have the comfort level of talking about these things and seeing it as a personal interest of ours that has to be resolved and dealt with. So we can continue to have school systems where, frankly, Black youth are just not registered by the school principals, and that's how they get rid of them. And that's been going on for years. So when you talk about the dropout factor that Marni mentioned, that doesn't surprise me in the least, because it's been going on for years in our community, but not been documented because the student is just not registered, so it doesn't show up in the data. Okay, it doesn't show up as a suspension or expulsion. Okay, so I think overall this notion of ourselves and our values do have an impact on how we proceed professionally. And I think the two great, I call them the taboos. No one wants to talk about wealth and income and class, and the secondarily, no one wants to talk about race. Now that's starting to change, thankfully, but I think it's a long haul to that change, and that's where we're at right now. You know, I noticed BC just recently passed some legislation that they're going to do data gathering with race identifiers. So, you know, step by step, it's happening. Thanks.
I see Marni has a hand up, and I'd also be interested to hear Aki's perspective around how governments are thinking about this. And I'll also just remind the audience, please put your questions in the chat. Marni?
Yeah, Astrid, I just wanted to add to this, you know, when we're talking about race and ethnicity data, and also, you know, the use of cross-sector, never fails. Sorry about that. You'll just have to listen to my phone ringing for a minute. But when we talk about these data, we have to keep in mind where administrative data come from and who's collecting them. And so much of what we work with in administrative data has been created within systems of oppression and colonialism. And so they really have systemic and structural biases baked in. And so, you know, if we don't understand that context, there's the potential to amplify systemic biases in the work we do. And I think it ties back to what Brenda said in her, you know, originally when she was talking about, you know, having the skill set of working with community groups. We really need to center the voices of communities who are oppressed by systemic biases when we're working with these data.
Yeah, no, thank you. It's actually a bit of an echo from the last session on data science and algorithms, right? I mean, that's, you know, some of the concerns as well about algorithms, you know, being trained on, you know, data that you say already have sort of baked in biases. So very interesting. Aki, I wonder if you could reflect a little bit on just this part of the conversation, you know, around, you know, how government is thinking about you know, addressing what we know, you know, systemic racism, and you know, the fact that we're not collecting data now, we know problems exist. Is the government kind of ready to, because there have been discussions about more collection, is that if we were to do then analytics, you know, on racial inequities, is government, you know, are they going to be able to sort of take these up and, you know, develop policies related to them?
Thanks, Astrid. I mean, I think both Brenda and Marni kind of just mentioned this as an issue. I mean, I think Brenda kind of just hit the nail on the head around mistrust. You know, this is basically a reflection of the issues that we have, the colonial history we have in our province. You may know that we have an act that mandates some sectors to start collecting identity-based data, race data. The school system, child welfare system are just a couple, and the youth justice systems. It's just not just only collecting, but also report. It is not an easy endeavor. Yeah, so it's just boils down to the mistrust issue that you mentioned, Brenda, and also the fact that our system is set up in that colonial history, and there's always that middleman that navigates between the services that we deliver on the front line and how data moves up, right? So there is, even our legislations don't really necessarily, program legislations I meant, do not really necessarily require. There's a lot of resistance from the system as well as from people who participate in that. And the fact that it is more like a voluntarily disclosed set of data in many ways, even though you have some idea about the race and other socio-demographic factors that you can pick up even as part of your conversation. There's a lot of discussion on that. There's a lot of resistance to that. And we've been really trying to forge ahead in that area, particularly around the indigenous communities that we work with, for example, in the context of the child welfare system. And as we kind of go through that, I know ICES has gone further away in some of those conversations with our First Nations and indigenous partners. So I think the question we need to ask is, where do we really put our efforts and you know, work together on this one? If there is some sector that has developed the necessary trust with the communities, with marginalized population and other race people. How can we leverage that trust as government to build good data and policy through integration and linkage and so on? So one of the driver in our current thinking is just exactly that, in terms of establishing an external integration unit out in ICES, because government has its own legislations, privacy legislations and others, freedom of information. How do we really give confidence to the public we serve that this information is actually used, to understand the issues that, Arjumand mentioned, that gap, understanding that, and also come up with remedies, solutions, and design programs and policy and investments that works for the public we serve. So I think that the bottom line is, we are on track doing that, but there's a lot more to be done, and particularly leveraging some trust that's already been built, that's already built out there, like ICES, for example, has a very good working relationship with the First Nation communities. How can we really build on that one? So lift that out. I think there's also other inequity issues that I think about around access to health services that in the marginalized and low incomes and subpopulation population is pretty clear, right? So I think when we put together a study, and a lot of your community members participate in this work around HCARD, healthcare access for research for persons with developmental disability, great seminal work. I mean, it is one of the things that really dragged me into ICES partnership with the scientists out there is that there is a lot of the time we think about, okay, so we cannot do that because the persons with developmental disability probably that don't have informed consent given to us, probably they don't have. But it's quite the contrary. People actually want to their data to be used in a meaningful way to design programs and supports for them, right? So the research team went out and really pulled out some very interesting gaps around primary care for persons with developmental disability. Huge gap. I think they were showing that also the impact of those gaps meant that, persons with developmental disability are twice more likely to return to emergency visits within 30 days. They are 3 times more likely to be readmitted into hospital within 30 days. These are like big impact on the health system itself. And then they are also nearly 4 times more likely to experience death prematurely. That's kind of just around 75 years or younger. And this is just scratching the surface. A lot of evidence, clinical and otherwise social evidence, as well as methodology evidence that was gathered in terms of bringing in kind of seemingly very difficult to use data into use through good methods around linkage, algorithms to link data between the health and social services system. Great stride on that. I would also mention, because you mentioned that, Astrid, earlier, that how we leverage this partnership in our space. I cannot really ignore the fact that we used the data platform that sits out at ICES to support our effort around response to COVID. We talked about the inequity around access, vaccination, and so on. But what we did with the data that we have, that we integrated between the social services data and the health data, is we were able to pull out specific interventions, or like vaccination rates, infection rates, and some of the outcomes, the health outcomes of death and other hospitalization outcomes from COVID. And we were able to break it down at a unit level, a local health unit level, so that we can then send it to the public health units to basically put a mobile clinic or intervene there. We've also done that with the social assistance. When you look at the data, the vaccination rate is amongst the lowest, probably the lowest among our social assistance recipients for a variety of reasons, right? There's mistrust, we talked about that, it's connected to race and other pieces. These are people with mobility, some other challenges, huge gap in vaccination. So what we did was we pulled that again and then worked with our local offices to work with their public health units to use mobile clinics and other interventions to support or increase vaccination rates, immunization among social assistance rates. Just using a couple of examples, how powerful when you bring in data from human and social services into the health system and the economic data together, there's a lot to use from a government perspective. So yeah, we are addressing the race data issues, socioeconomic, demographic factors, and we're getting better. But I think there are also huge trust gaps that we need to work on and build over time. And then meanwhile, we can leverage organizations like ICES who have a very good trusted relationship with some of the communities out there, because I mean, that's what I said earlier. You have a real comparative advantage compared to government because you're kind of seen as also
a step away from government.
An arm's length,
yeah. And I, if I could add to this, it's important to realize part of the difficulty working with community organizations of that level is they're not organized in the same institutional manner that governments are. So there is no one group you can go to that represents the Black community, for example. It's Black communities, plural. And even with the Aboriginal community, First Nations community, depending on the province you're in and how they're organized and whether they're part of the regional chiefs or whether they're part of AFN, et cetera, et cetera. So I just want to warn people, it's not a simple thing of just add and stir. You'll have to work hard on this. And trust is only gained through work, right? The proof's in the pudding. When they see that what you're doing is worthy of trust, they will trust you, they will work with you. It's not, it's not always negative, but it just takes time. And one of the ways you can show and develop trust is the utility of the data you're attempting to gather. What's it going to be used for? What's in it for me? I think it's quite important for any partnership, whether we're talking here government or community organizations, it's quite honest to say what's in it for me. Why should I collaborate with you? What will I get out of this? And I think that's a very, and I say it up front when I'm in partnership meetings, okay? Because if you can't get people understanding why we're coming together, then why would you think they're going to continue in a sort of engagement process? So I just want to say that every community is different and some are more organized than others. You may have to work harder to have a connection with it, either geographic or an ethnic-based or race-based community, but you have to do it at some point. And if it's not you, then someone else will have to do it, okay? And it will work out in the end, but you just have to understand the time commitment, the element of almost not mutually exclusive priorities, but there is a certain inherent tension. What you as a researcher or research institute or government institute want to do, it may be different than what I want to do at a community level. And the issue will be trying to find that Venn diagram where we can meet in the middle of something that suits us both. But understand it will take work. But otherwise, if you don't do it, then you're going to run into issues of credibility and utility. I mean, we know we can collect lots of data on poor people, but so what? You're going to run the risk of just proving the inevitable of proving. I'm not interested in data that's just going to say Black people are a certain percentage of poor people or, South Asians or this or that. It's got to be a little more depth to it, a little more subtlety to that. And we saw that with COVID because, initially data was used against the Black community, showing how they weren't getting vaccinated. Well, when it was properly interpreted, it then meant institutions, public health, what have you, started to work with the Black community to try and address their concerns. Why is it? Well, if you understand the Black communities, they have certain values about natural health. They have certain values, particularly if they're Seventh-day Adventists, because they have an alternative healthcare system that make them a little hesitant on these things. It doesn't make them anti, but it makes them hesitant. Well, no one knew that and no one planned for that. Instead, they blamed the Black community. So it took some turning around to understand those unique differences in the different communities instead of blaming people. And that's an example where the data could have been used disastrously, blaming South Asian and Black communities in particular. And whereas they were the two ones that pivoted better in the end than most others. But that took work in the community.
For sure, and it's an excellent point, and I think Aki's comment about the way in which ICES has approached partnerships with Indigenous organizations and the use of the data. I mean, that was not just trust building, but also, of course, very clear, goals around who governed those data. That's really important. But just thinking about, again, we're talking about, some of the data that we're talking about here, and Marni's alluded to, and I'd be interested to hear from her. We're talking about child welfare data.
Yep.
I mean,
Yep.
very,
That's really important.
sensitive data. And I think there's a question from, the audience as well of how you promote the trust within the communities. And certainly at ICES, I think we have to have an institutional approach, not just, not just leave it to individual researchers who have an agenda and often do very appropriate and really well thought out community engaged research, but this is also sort of an institutional initiative. So Marni, I don't know if you have any words of wisdom about some of that trust building, especially around, again, I keep coming back to child welfare, but other social, even, active ministry, social services. I mean, these are often services that people don't, want others to know that they use. And the fact that we're bringing so many different, or juvenile justice, I guess, Marni, so many that you've used. So any advice that you have to us around, the trust building?
Yeah, in terms of our use of the child welfare and the youth criminal justice data in Manitoba, both of those data sets, there's a overrepresentation of Indigenous youth in both of those. So, we've just made it a policy at MCHP that we will not work with those data without the partnership from Indigenous organizations, whether it's the First Nations Family Advocate Office for the child welfare data, or another partner. There's the Manitoba First Nations Education Resource Center that we partner with on educational outcomes. Just ensuring that those partnerships are there. And I would just add to what others have said, that these things take a lot of time and a lot of patience. And you have to keep investing in that in order to build the trust.
And Marni, do you also have particular ways of ensuring the sort of other types of community engagement in the projects, sort of resources that the Institute sort of uses?
Yeah, we're starting more with that, and we actually have what we call a partnership building called Spectrum, where we are trying to reach out to different community groups, different community organizations, individuals with lived experience, academics from different disciplines, and then government staff from different ministries to all work together. If a particular project includes child welfare and whatever, you look to those with the experience and expertise from those different groups to come and work on the research team. And again, I'll tell you, it's not easy. I mean, we're working on a project now that took us a year amongst those groups just to decide, okay, this is what we're going to focus on, because everybody is coming with different perspectives. And it takes a lot of trust building, but eventually, we all recognize that we have the same goal, and that is, improving the outcomes in this case, improving the outcomes for kids and families.
And maybe building into your research budgets staff line for this function.
Yeah.
Whether it's your contracted staff or outside people or your own people, just understand it's staff time. It takes time. It can be done. It just takes time, right? So build it into the budget and just accept it for what it is. And also understand how it may change. You may have a good working relationship with a network of organizations now, but that could change. So you always have to continually revise it and continually keep on your toes with building trust and engaging with organizations. And it will work. I know it will. I've seen it, but it takes the time and understanding of that it's important to do.
Thanks, Brenda.
And child welfare.
I know you want to, oh, sorry.
And child welfare data is really interesting because it's almost a reflection of the failure of other systems. The reason that kid is in care is not because of the family. Let's make that understood. It's because of the breakdown of all the other things. You know, why are 40% with 45% of the kids in care are Black? There's only 8% of the people are Black in Ontario. You know, what's wrong with this picture? And similarly out west, I'm certain with First Nations and numbers, and even in Canada and Ontario, we have very high First Nations numbers in child welfare. And there, it's often said, you know, but it's understanding it's good, useful data because it reflects that breakdown.
Marni's just put a comment in the chat. It's the same as the justice system.
Well, there you are, 90%. Well, there you are. Yeah.
Oh, very important. Arjumand, I know you'd wanted to pop in. Do you have what on the conversation we were having a few comments ago?
Yeah, thanks. I was actually thinking about your original question to me about what data we should collect. And I've always wondered about, you know, making sure that we think about whether we want to collect data throughout the socioeconomic spectrum. And so we're focusing right now a lot on what it means to collect data from communities that are oppressed, marginalized, et cetera. But for a variety of reasons, including the fact that inequity is really about figuring out why some groups are doing worse than others, rather than why some groups are doing badly in some absolute sense. I always wonder about making sure that we have data on who's doing the best, because that's a big indicator of how far behind we are for groups that are heavily disadvantaged. So it's one thing to figure out whether, for instance, an income supplement helps people who are poor become slightly richer and do slightly better. It's another to understand how far they are off from the best outcomes in our society. And I think having data for high income folks, for white folks, having all their information becomes pretty critical. It's also critical for technical reasons related to how we do research on inequities. But I think the sort of bottom line is that it makes sense to think about having data from the entire population and having just as rich data from the entire population.
That's a good point, because if you look at income data and government transfer data, if you really analyze it, it's not just the child tax benefit helps the poor folks, but all the other tax deductions that help all the other folks. So, you know, the money that we lose in tax revenue through the various deductions that benefit high income earner people. Then we look at the money we give in direct government transfers, like child, whatever they call it, what we used to call a baby bonus, but now it's child tax benefit. Who's benefiting where? And we saw that with COVID, you know, where did, you know, CERB did so much, but the grants to private sector were just enormous, ginormous.
Yeah, no, it's a great point. I think that's a wonderful way to, those are very important considerations, and just wanted to extend my thanks to the panel. It was a great conversation. There's so much in here, and I think we'll be having many more conversations about this. Oh, sorry, Aki, did you
can I just make a quick
word?
Yeah, can I just make a quick
Yeah,
point?
for sure.
I think I just want to send a message to the researchers that research is critical, but at the same time, I think it is very important that that is built into more of a program where we have community and government knowledge users embedded into how you design your research and use it. So I think I just wanted to make that. And also as an organization, ICES, I think I know the focus historically has been on the clinical studies and research. As we move into more social determinant, we need to bring in more and more of that social services or social communities that will support the governance and the board and other things in terms of kind of setting the strategic priorities. I live that. Just want to make sure that those are considered.
No, thank you. That's very all important considerations, and we're grateful that we'll continue to work with you, you know, as we move forward, and you know, think of how we, you know, make sure that that happens, you know, not just at that institutional partnership level, but as you're saying, like project level as well. So thank you. So again, I'm going to just my warm thanks to the panelists. This was a great discussion. I feel like there's so many things that we could continue to discuss. I think we have a small break now, and coming back at quarter to two for the final plenary.
Thanks, Astrid. And maybe I'll
Thank
just
you.
jump in to also thank the panelists, but remind folks that we're coming back at 1:45 to listen to our keynote speaker, Alisha Aslam, and then also the closing panel, which is going to be terrific, with Teresa Scassa from the University of Ottawa, Stefaan Verhulst from the GovLab in the US, and Andrew Morris from Health Data Research Network UK. So please take a quick 10-minute break to rejuvenate yourselves, and we'll see you back at 1:45.
one.
Hi, everyone. Welcome back. I hope you got a little bit of a break and got a cup of coffee, glass of water, something to eat perhaps, and are ready to buckle in again for the second half of our research forum. I'm very excited about what we're going to be hearing over the next half hour, which is our keynote speaker, Alisha Aslam. Alisha has been featured across Canada for advocacy for positive social change with youth at its center. Through her service on numerous councils and change groups, 16-year-old Alisha's words have had an impact on many around the world. From being co-chair of the Toronto District School Board's Student Senate to being a page at the Assembly of Ontario, Alisha has drafted policies on behalf of Ontario's youth, collaborated with the US Consul General in Toronto, written for UNICEF, provided STEM opportunities to marginalized youth, and written articles that empower youth to persevere despite hardship. Alisha aspires to bring the unity in community and help build a world where youth not only survive, but thrive. So we're delighted to have you join us, Alisha. Take it away, over to you.
Yeah, thank you so much for having me. First of all, it is truly an honor to speak at this event, and I'm really excited to see what I can learn from everybody else as well. First off, I was told about the myriad of people attending today, and I cannot start without saying thank you. I know you hear this a lot, but honestly, to the frontline workers, researchers, scientists, your struggles and hard work has taught us to not only appreciate your quick turnarounds, late hours, and strenuous schedules, really, but that you've been underrated, frankly, for a really, really long time. And it serves more than a lesson for us to keep this gratitude in mind, even after this pandemic is over. And trust me, after doing physics and chemistry and biology for a semester this year, I really do admire that some of you sat through this in university. So I applaud you even more on that. As well, I'm going to address data because last century and last decade alone, our advancements have exponentially grown. And for those who've grown up with it, like for a lot of people like me and younger than me, it really doesn't seem like that for us for a lot of the time. But if there really was an entire graph of the world's developments, the spike would be very, very steep because it's gone up very, very high and very, very fast as well. And I think that our advocacy can channel its duality to do good. Because if there's one thing I've learned, we have power. And some of us obviously have more power than others, like influential figures or like policymakers. And that's why your role is so crucial, because no doubt the question is how we use that power. And I have faith that our intelligence and our species can overpower anything else. Job titles and everything else aside, the world doesn't run on its laws. It runs on its citizens. And that's all of them, including you. I'm Alisha Aslam, and as a 16-year-old youth advocate, I work to make it more inclusive for youth to not only survive, but thrive. Writing was and still is my idea of enjoyment, for ever since my sister and I were little, we'd be flooding papers with our stories and household newspaper we made where our parents were our only subscribers. And as I grew up, I started using this for advocacy and for speaking up about my community, because as I grew up, I saw a lot of issues or a lot of topics that needed more youth representation. But before I talk about that, I think it's imperative to lay a foundation. Ever since I've been in school, I joined all the extracurriculars I could, especially like leadership teams, and I loved playing the violin and alto saxophone at school. For years, I fought for youth to be at the center of change, and I'm in grade 11 now. After I became a page at the Assembly of Ontario, my horizons broadened as to what I, as a member of the youth community, had the power to do. So when I saw all these issues happening around my community or around the world, I wrote articles, and honestly, I didn't really think much of them. But I was really desperate to get attention on these important issues because nevertheless, I had faith and power in the good of the people. And ironically, especially when my voice wasn't being heard and I was getting rejected a lot and kind of, my articles weren't getting much traction, I guess, I developed more of a drive to keep going, of course, after mulling and rejection. And it could not have been done without the community that gave me so much, because more than everything that it gave me hope. And I finally saw the light when the media highlighted my articles, such as the CBC, Globe and Mail. I wrote multiple articles for UNICEF, and still, I felt like there was more change that could be done. Under many other people's posts, like my peer advocates and activists, as well as some of the articles that I wrote, I still saw comments that were hate comments. And I am someone who takes a lot of things to the heart, But this taught me that there will always be hate, unfortunately. But our goal should be to overpower it with love and make sure that no one ever feels this hate again. And a lot of you might be thinking that how does this really relate to the technical, I guess, subject of research? But this is a broad field, and that's why I think it applies to really every walk of life. This applies to law, this applies to the sciences, the social sciences, and really every other technical science. Because before we work on, our jobs and our employment and the economy, we work on each other and we help each other grow. So I hope that you can find your story in mine. I went from volunteering at the library 5 minutes away to speaking for 5 minutes at the United Nations. And I'd like this to be proof for you that all it takes is one idea. I've joined so many councils and been in rooms where I was the only female, the only kid, and my personal favorite, the only one rubbing her sweaty hands in her pants, worried with backup plans for backup plans just in case my ideas were invalid. I now know, and it's what I'm going to tell you. There is no such thing as an invalid idea. It is scary, there's no doubting that, speaking up and channeling other people to speak up with you. But an idea is simply a thought that has a purpose, for better or for worse. And what purpose is for you? Well, that's subjective and for you to find out for yourself. Now, throughout this and everything that I did with my advocacy and everything that I've talked about so far, I actually also helped with some research at U of T with a few graduate students with coding and engineering, and I volunteered with the STEM Fellowship of Canada for 2 years to cater to marginalized youth. And the reason why I think that this is so important to mention is because I often thought, like many others, that you need to pick one or the other, that these two fields that I was really interested in, and I was interested in both of them, were like oil and water. They don't mix. And especially with the environment I grew up within, it was either that I felt that I had to pick my passions for social sciences or really what my activism is, or the technical sciences, because both offered me such a huge world of their own, and both offered me worlds of new discoveries and new ways to meet people. So I did feel torn between the two a lot, especially when it came to, course selection, everything like that. But when I'm done talking, I hope that you'll realize what I did after watching documentaries of scientists like Einstein and documentaries of politicians from all over the world, as well as after meeting with important figures from all walks of life, that we may come from all different worlds and all different journeys, but at the end, we're all in one world. And it really means that we are all the colors in the beautiful rainbow that isn't noticeable a lot, but it's there. And I found enjoyment in where these two fields meet. And I always, sort of formed my thoughts on this, but I kept it in me for a bit. And that's why I'm so, so thankful that this organization gave me this chance to share my thoughts on these issues and on this advocacy that we continue to do. This pandemic has, in fact, exposed concepts, which I'm sure we can view this as an advantage by learning from it. But nevertheless, the concepts that it has exposed were detrimental truths. And I'm not talking about the COVID-19 pandemic. I'm talking about the viruses that have brought pain and suffering to many, even before COVID-19, like hate, chaos, and inequity. They loom far beyond the reach of COVID to the lungs because they go further than that. They infect our hearts, our spirits, and our minds. And the cure isn't something that only I can give, or a university student can give, or even that a politician can give. It's something that we all contribute to, and we need each other. We need facts to back up our policies and actual action to back up our dreams. Health, according to the World Health Organization, is, and I quote, a state of complete physical, mental, and social well-being, and not merely in the absence of disease and infirmity. And that makes sense, definitely. I'm sure we can all agree. And we all have health. But doesn't that mean that everyone also deserves access to it as well? That's the only way that we can really achieve universal health. And we like to say anything is possible, but right now, for many worldwide, it's not. And I've used COVID as an example, a lot recently. So what about infant health? The American Clinical and Climatological Association reported that infant mortality for Black babies remains nearly 2.5 times higher than for white babies in 2012. And Medical News Today reported in 2021 that the fact that there's no other reason for this but inequity demonstrates that the higher rate of infant mortality is not natural or inevitable. You see, you're never too young to feel a loss, as the very foundations of our society, babies and children, they face this. But you're also not too young to feel loved, and we need more of that. As per an African proverb, it takes a village to raise a child, and we are that village. And you don't need to be an economist to know that bettering our health prospers the health of our economy as well. Attaining both, that sweet spot, that's a very, very huge promise. And it does seem far-fetched for many. But what do you do after you've gotten riled up with passion and attended debates and, educated yourself on the issue? You start listening, reading, showing up to town hall meetings, showing up to volunteering meetings. You get involved and you take action. And that starts with starting, just like you all are doing right now. The resource that I presented to my school board, which was one that I made in 2020, I called it Change Starts in the Classroom, because that's where those my age spend most of their lives right now.
You gonna make it through that one day?
And even after graduating, and even after I do graduate, I learned that that's where my learning, it doesn't stop, and neither does yours. Education has a start, but it never has an end, and you can start anytime. It isn't limited to just your graduate degree or undergraduate degree, or for me, my high school diploma. It's really not limited, and it continues all the time. So you can start now, and that is a root of change in the nascent campaigns that we're observing today. You see, don't at me, but I think that performative social media activism can be harmful when activism begins and ends with social media. And this translates to advocacy in health and advocacy in data and advocacy in really inclusivity for people of all age groups and all races and all ethnicities. Because performative activism says here, read this and do something. But if people read things and did something, every student would be passing classes with flying colors. Every home cook would be excellent. You can take that from me because I'm definitely not. And robots would be replacing emotions already. This means that there's a fault in the system that we've created. And while I'm saying this, I don't mean to tell anyone to stop, because social media is actually very, very helpful to advocacy. But we often let the barrier of performative activism replace real and raw activism. And this translates to the gap between the policy and the people. However, there is a bridge over this. Instead of only holding Instagram or Twitter or Snapchat accounts accountable, we can hold ourselves accountable for actual action, online and offline. We can't let the tweets on Twitter drown out the tweets of birds outside. And we can't let the advocacy on our Instagram story go down after 24 hours. So what do we really need to do here? We need to start conversations and start movements in places where these topics haven't been so prevalent. And again, this starts with us. And I'm saying this to you, not as an advocate or as an activist, but as a 16-year-old, because the future is tomorrow, but tomorrow never, never comes. It's like saying you'll get to checking my email tomorrow, or me saying I'll go study for that quiz tomorrow. The future is today. It's all ours, and the world needs all of you. So that's why I'm calling on everyone. Rather than being a call to just one person for one event, this is a call for all of us. For people like me, it's a call to advocate even more and continue to show up, write, and deliver change. And to others, it's a call to start advocating. And you've started anyways by being here. It's a matter of humanity, and that's what each and every one of you carry in your hearts. Not allowing others to be educated on inclusivity will only breed exclusion. So it's in our best interest to act accordingly. And a lot of people, while I've done my advocacy and while I've done interviews for multiple, podcasts or news platforms, a lot of people have asked me, do you think the government's doing enough? Do you think your school board's doing enough? And my answer to that is that the fact that you're never, ever done creating change shows how committed we are to shaping safer communities because of the fact that we have a common goal to do so. And that's really what advocacy is. And that's really what we all are doing here. Because I know we all can agree, we all recognize there are issues that need to be heard and others that haven't even been addressed yet. And that's exactly what this forum aims to address, that there's really always more to address. I don't think activism or education, anyways, never has an end. There's always more to do, and this is creating progress. We can turn the impossible into possible together. We can build a world where each citizen doesn't only survive, we thrive on common ground, across the ice-old Atlantic and the breathtaking views on our East Coast. And really, this starts with small actions. I remember when I, first started advocating, and I wasn't even advocating, I really first just started volunteering. It was that really, got me into the community, because I learned from early on that one hand is for helping myself and the other is for helping others. And I went to the library, I went to food banks, I went to helping community initiatives in my school. And, never take those for granted, or never take those as a very small thing that doesn't matter, because especially at my high school and my board, it's a requirement. You have to complete 40 hours to be able to graduate. And that is amazing. And a lot of us do it, but often we do it just because we need to complete those 40 hours. But the point of us doing that is so that we, get that habit, is so that we gather that habit of volunteering and we can continue it, onto our other walks of life and after we get a job and after we graduate. Because I really think that those habits that we build, those are what help us. Those are what help us further our community and what help us really make the community stronger. In science class and from an early age in life, when I was reading books about stars and about the universe, I learned that the speed of light is the fastest thing in the universe. And I'm sure we all know that by now. But the strongest force in the universe is our interpersonal connections, our love. Everyone's different, but doesn't that mean that anyone can fit in? By the end of this, society shouldn't seem like your friend who moved away. It should be your community, and you must put the unity in community because you are a member of society and you are a valuable one at that. So it's not in our best interest to refer to society as a third person. And sure, maybe it does sound naive because I struggled with this a lot, that my idea of an equitable society was too far-fetched. But if we made countries change perspectives and conducted the eye-opening research that this organization does and many organizations do, then who's to say we can't do this? I have faith in the good of the people. Politics and our intelligence and everything else that's really measurable has had a beginning and will have an end. But human rights and interpersonal connections have been here ever since we walked the earth. While a child might need to study to understand government or science, and we usually do need university degrees or some sort of education to get a grasp of those concepts, human rights for every person are universal and they come from unity. They come from us just by being human. So there's really no argument that we deserve optimal access to health, for instance, and I know we can all agree that here. It's just that we have different ways of arriving there, and that's totally okay. To help us steer in the right direction, we need unity because a bill passed in government affects a family on a quiet street struggling to make ends meet. And that effect is where we come in. Unfortunate instances that we're seeing all around the world that have been heightened, especially due to the pandemic, and that have been here before the pandemic as well. It's not the first time that these things have happened, but together we can make sure that they're the last. We need to come together and embrace our differences, not try to find a spell to get rid of them. Within all of the chaos happening in the world right now, I know that there's a lot of us who still want to create change and who still believe in the better of tomorrow and the betterment of all of us. And really, that's what makes political changes. That's what also makes our synergy really get highlighted. And that's what gets reflected in our learning, like, law class or science class or anything like that. Because I took part in the Model Parliament program at Queen's Park a while ago, and I saw firsthand that when we're making policies, when we're doing this, it's great to know how to make a policy, how to draft it, how to use the proper language. But to make that policy, we need the components of that policy, and those components are the people, because the policies are ultimately for the people. And as a youth advocate, my main target audience is usually youth and people of the youth diaspora. But a lot of times in my talks, I have addressed people of, all different walks and from all different stages, because I think that each of us offer a different thing and a different idea to the table. So we can't do it without you, and you can't do it without us, which is why we all need to work together to create policies, to create advancements that help people instead of harm people, and to create more ideas that benefit all of us in the end, because together we can do so much. A leader doesn't create more followers, they create more leaders. And a lot of times, I learned this through my leadership, is that yes, you definitely want to lead more people and let them know, where they should go and help them around. But that's the difference between a boss and a leader, that a leader creates more leaders. And I think that that's what all of us should aspire to do. And I think a lot of you are really doing it already just by being here. I think each of you have your own version of my story, and that we've been challenged against multiple times throughout this pandemic and before, and even now. We've went through uphill battles and we continue to do so, but no one is impaired from making a change. And that's why we're here. If we can make progress together, we can see beyond sight, and that is optimism to me. Everyone could, anyone could and everyone should pitch in to make these differences. And you do that by attending, you do that by speaking up, and you do that by showing up. This change doesn't lie in your hands, it lies in your voice. And it's all of our duty to play our part in making this change. And so our footprints can add up to the wonderful diaspora of the rainbow that we see today in creating change. Thank you so much for having me. This speech was really, really important to me because it highlighted a lot of the different ideas that I felt. If you would like to check out some of my other speeches, my Instagram is my first and last name with an underscore at the end. That's ALISHAASLAM with an underscore. That is the one that I use most. So please feel free to let me know, what else you'd like me to do and other topics that might be important. And I just want to say thank you so much for having me. I really, really do appreciate it. And yeah, over to you. Thank you so much.
Wow. Alisha, that was awesome. That really was fantastic. Truly one of the most memorable keynote presentations at our research forums that I can remember anyway, and I go back quite a few years. So thank you again. Just for a reminder to the participants to put your questions in the Q&A. We have about 10 minutes left for questions with Alisha. So I have a couple for you here, Alisha. And so, clearly you're part of the generation that is going to need to solve many of the major challenges that you've described and others that you didn't describe. And I'm curious, you mentioned that you often are targeting other youth, but also other folks. So what are your strategies to increase the engagement of other youth like yourself in the kind of efforts the campaigns that you're waging or will be needed, but also to engage with people who are older than you to develop, perhaps an even stronger movement?
Yeah, for sure. Thank you so much for the question. I really think, yeah, that's a great question because oftentimes, movements are categorized as youth movements or movements, for different, I guess, age groups. And I was seeing a lot of that happening and it was really, really good to see it. But ultimately, I saw that in the end, even for movements that are directly for youth or the advocacy that I do, which mainly only does affect youth, like the ones in schools or the ones at the school board, we still need, everyone's input. And to sort of, reach out to those groups, it was important to highlight the experiences that all of us bring, because us youth, we have a lot of passion, we have a lot of, we recognize issues and we have a lot of that. And I think that the really good thing that the generations that are older than us bring, which is the ones that, when I was for example, in the school board student senate, we weren't only working with other students, we were working with staff and we were working with trustees at the school board. I think that what they really brought was the knowledge on how to do these things. And they made it happen way quicker because they knew how to draft those things. They knew how to take our opinions into account and sort of, make them into the organized, documents that you see today. So I really think that even if, an issue affects, for example, only one group or only one group at your school or only your friends, it's also your duty, because as Canadians or as citizens of the world, really, we have a duty to play a part in everybody else's change making as well. And it's important because, as much as it's important to also not speak on behalf of them, it's also important to highlight them as well, because our role in that determines so much. And it makes processes speed by way quicker when you have everybody on your side, because ultimately we all bring different things to the table and we can never do anything with just me or just you. So we definitely need all of us there.
Terrific. Let me ask you a different question. We've all heard, and I'm sure you have also known about, maybe through friends of yours, about the challenges of mental health in youth, especially over the last couple of years through COVID, but even before that. And you mentioned sort of this risk about performative social media, where you just kind of throw out a tweet and you expect great things are going to happen. I think that's also a risk for researchers, where we put out studies that might be addressing issues like mental health in youth or other health issues, and then struggle to see them actually result in real change. So what's your advice to researchers, folks like us, who want to be engaging with youth on some of these issues, to understand their challenges, their perspectives, to find ways to better share the results of this research, better engage them in the process of conducting the research and working together on solutions.
Definitely. I think that, the representation of research and policies is something that I've also seen firsthand a little bit, because I was in the Ontario Provincial Youth Council for a bit, and we were sort of taking research that was done in Ontario and trying to really put that into policy. So I really do see where that's coming from. And yeah, it definitely is, because a lot of times there are some really fantastic studies that come out and some really, really interesting and eye-opening things that, even I see on the internet or somebody sends to me. But the key to, seeing that actually happen in actionable items, like in seeing that implemented, is representation. So I think that, we need more of, instead of just, having a sort of black and white picture of this entire scope of change that we want, we need more of, a mix, because we need researchers in the policymaking positions, and we need policymakers in the research making positions. And I think that how it translates to really youth is that that's also one thing that I advocate for, is more representation for youth. So I've been fortunate to be in a lot of roles where I've gotten to see firsthand that representation, but there's obviously room for more, and there's obviously room for more for researchers as well. So I think that that is such an important thing, because oftentimes we all do our part very, very well, but we often forget to make it intersect in that way. And so we can see each other's changes, because that's the only way that I think that research can be reflected in what we see. And I think that that sort of collaboration definitely needs to be more prevalent, because a lot of times when people are focusing on a policy, it's really about that policy. What about its effects, So that also needs to be in the same, I think those need to be in the same conversation, the same meetings. We need more people from all different sort of perspectives and all different sort of fields to be in the same room working on one policy, because I think that that will really make sure that we all, take everything into account, and we all highlight each other's sort of strengths as well.
Great. Well, we have a couple of minutes, just like 2 minutes left. So here's one last question for you. So based on your own experiences, what do you think is the most important thing that we must do when it comes to addressing inequities in healthcare, some of the things that we've been talking about today, and some of the things that you spoke about in your comments?
For sure, yeah. I think there's definitely obviously room for a lot of the things we can do, but the one thing that I think that would probably encompass all of them is education. A lot of times, it's that some of us, simply just don't even know about the issue to make comments on it. And we have a lot of people who know a lot about the issue, but they aren't given a platform to make comments on it. And we have the reverse. We have a lot of people who, don't really know about the issue, but they obviously speak a lot on it. So I think that we need sort of a balance between the two, because that is such an important thing. We need education. And I think that especially with research, I think that that's what we need. We need more of that. And also, after we've been educated and after we're making those changes, I think the one thing to keep in mind for youth, and especially people of all different generations, is that a lot of us don't think that we can make a difference. And so we educate ourselves on issues and we say, yeah, like, I definitely think that something should happen. But that often, we don't think that our voice has an impact on that. And so that's really what I think that my advocacy also really aims to address, is that you do have an impact on that. So I think that's really important that we all take it upon ourselves to show up. And, it starts from little things, like you can even go to the library, you can, do a little bit of research at a university that you think that it doesn't matter, but it opens up so many more doors for you and so many more doors for your mentors and everyone else. So the key is really to just start, because you do have a lot of power. So never, ever forget that.
Fantastic. Listen, thank you so much, Alisha, for your comments, for your thoughts, your participation. I think that the term "wise beyond your years" was invented for you, and you've given me, and I think lots of people listening, great confidence in the future, knowing that it's going to be in the hands of you and your friends and colleagues going forward. So thank you again, and I look forward to learning more from you in the future.
Thank you so much for having me. It was truly an honor to be here. I really do admire like everyone who came out, and everybody from all the different fields. So, and I look up to you a lot as to what I can do in the future. So thank you so much.
Okay. So that was terrific. That is Alisha, Aslam, so we'll now transition into the last formal segment of the research forum, which is our closing panel, which I'm going to moderate. So there's no need to introduce the moderator, but I am going to introduce the speakers. So the panel is entitled "The Next 30 Years of Data in Canada," and like the previous panels, and Alisha's comments for that matter, it is future oriented. We're really thinking about what's going to come, and I'm really excited about the panel and the speakers. I think I know them all, and we've had a chance to discuss a little bit in preparation, and I think it's going to be a really fabulous last hour. So we're going to start with Teresa Scassa. Teresa is the Canada Research Chair in Information Law and Policy at the University of Ottawa's Faculty of Law. She's a member of the university's Centre for Law, Technology and Society, where she is part of the Scotiabank Artificial Intelligence and Society Initiative. Following Teresa, we'll then hear from Stefaan Verhulst. Stefaan is the co-founder and director of the data program at the Governance Laboratory, or GovLab, in the US, where he's building an action research foundation on how to transform governance using advances in science, data, and technology. And then lastly, we'll hear from Andrew Morris. Andrew has been the inaugural director of Health Data Research UK since 2017. He is seconded from his position as Professor of Medicine and Vice Principal of Data Science at the University of Edinburgh. Andrew convenes the International COVID-19 Data Alliance, which is supported by the Bill and Melinda Gates Foundation and the Minderoo Foundation. So with what the format is going to be, each speaker is going to talk for about 10 minutes, and then we'll have the remaining half hour or so to take your questions and questions. And I'll just remind you to use the Q&A chat on the online platform to enter your questions. And with that, I'll turn it over to Teresa.
Thank you so much for that introduction, Michael. The topic of our panel is the next 30 years of data in Canada, and I was asked to address some of the law dimensions of legal and regulatory context. 30 years is an interesting period of time. We are in a period right now where we are expecting in the middle of major reforms to data protection laws in the public sector, health sector, private sector. And many of these reforms have been a long time coming. And so if you think about the next 30 years of data in Canada, it's almost as if what we get in the next few years in terms of legal reform may be what we have to live with for the next 30 years. So it's really an important time in terms of what's happening in the law and policy context in Canada. We are obviously in a context in which the tools and technologies that are used to derive insight from data are growing in terms of their power and in terms of their demand for access to large quantities of high quality data. And we really are in a context in which privacy and data protection laws have not kept up, but there are lots of ideas for how they might keep up, and some of those we're starting to see creep into the legislation. So I thought I'd talk about a number of different trends that I see that I think are going to be important in this area. The first of these is the shift in the sources of health data. Typically and traditionally, health data has come from the health sector. Some of it has also come from the public sector in terms of some social data and also some health administration data. But we're starting to see the private sector becoming a growing source of health data. And this health data is coming from a large variety and range of health and mobility related apps, from Fitbit to sleep apps to, there's just any number of them now, as well as services like Ancestry.com, 23andMe that are doing profiling of DNA and so on, genetic profiling. And so the private sector is generating more and more health data. They are also involved in the development of smart medical devices that are often used in conjunction with healthcare, but will collect data for private sector actors as well. And they are also playing a role through data from other sources that aren't specifically medically related. And here, for example, I think a prime example is social media data. And we're starting to see the mining of social media data for all kinds of medical insights. And so this is a growing trend. And one that I think is going to have a significant impact because there's such a gulf between how personal health data is protected under personal health information and how it is protected under private sector data protection legislation, with obviously a much greater level of protection being afforded under the specific health information legislation. So that's one trend I think that is interesting and will be important to watch. Another trend relates to patient control and autonomy. And of course, this has always been part of the balance between the privacy interests of individuals and the needs of organizations to have access to data and to use data for a variety of different purposes. And consent has been a big part of that element or that dimension of patient control. There have been a lot of problems with consent over the years, and certainly in the private sector context, we talk about consent being broken simply because of the ways in which people are asked to give consent to things which, functionally give them relatively little control. It's obviously better in the healthcare sector, but as I mentioned, the dynamics are changing. And what we're starting to see overall are changes in how we are thinking about and operationalizing consent in different sectors. And I think one of the things that we might expect to see is more granular consent, as well as in a broad range of contexts, as well as in the research context. And what I mean by that is that right now, in the context we currently have, personal health information statutes typically provide for the use of personal health data without consent in certain circumstances where it's impracticable to get to consent and where the data is going to be used for research, and then there are other protection mechanisms put in place. If you look at a bill that was recently introduced in Quebec, you'll see that this bill reflects a move towards this more granular type of consent that I'm talking about and this is a bill specifically for personal health data. And it provides for individuals to consent to the use of their personal health information for research at the time of collection, but they can also refuse to consent to research, or they can consent only to research in certain categories or by certain categories of research. So for example, they can say, yes, you can use my personal health data for research, but only for public sector researchers, or only for hospital researchers, or only for private sector. So the idea is to give individuals more control upfront as to the uses to which their data will be put for research purposes. That carries over to the research data context under that bill, because what it means is that in those general provisions where you can use research data without where you can use personal health data without consent, there's an exception to that where the individual has already provided what their parameters are for the use of that data. And so where an individual has said, you cannot use my data for research, then that data is excluded. And so it is a more granular form of consent, but as you can see, it does raise some challenges, particularly for diseases or conditions that are more rare, where it would be more important to get as much data as possible, and you might have people opting out. And so that could have an impact on overall data quality. But this granular consent, I think, is becoming a trend in a variety of contexts. And so trust is going to be trust and communication are going to be tremendously important to ensure an appropriate supply of data. So I think this is something that we need to think about. Another element of consent or control by individuals relates to data portability and data mobility. And this is a trend we're also seeing in data protection laws. It's designed to enhance individual control over data, while at the same time enabling greater competition and access to data. And so we're seeing it predominantly in the private sector context, but it could be coming to the public sector and the health sector context as well. And so, for example, recent Ontario amendments PHIPA would introduce a kind of data mobility for personal health data through the concept of consumer electronic service providers, private sector companies that help individuals manage their personal health information. We're still waiting for regulations to flesh out what this will mean. So it's not in force yet. The amendment is there, but it's not in force yet. We're waiting for the regulations. But this will be an important and interesting development to watch because it could eventually evolve into something that impacts research if consumer electronic service providers become clearinghouses for consents to uses of data for research purposes. Another issue I think that we're starting to see arise in a variety of different contexts is the concept of group privacy. And this is interesting because research has often relied on things such as de-identification or other privacy protective technologies to enable research on data that has been de-identified and therefore can't be linked back to particular individuals. The concept of group privacy as it is evolving suggests that parameters for use of data may be necessary even for de-identified or anonymized human-derived data, and that might involve some form of community consent, and it might also involve some sort of benefit sharing with the community. And so this is all still at the very early stages, but we're starting to see these claims to collective interests in human-derived data in a variety of contexts that came up in the Sidewalk Toronto context, but we're also seeing discussion of these in the context of health research as well. So it's the idea that the collective has an interest in the data, even if it can't be linked to a specific individual. And so again, that's another trend I think that would be interesting to watch. How privacy preserving technologies are dealt with in data protection laws is a matter of interest, and again, something that is worth watching. Most legislation has been structured around the concept of de-identification, which is a challenging concept, and increasingly we're hearing that true de-identification is impossible, which raises further governance issues. But there are a whole range of privacy preserving technologies that are evolving, many of which don't hinge on de-identification. So pseudonymized information is identifiable information under contemporary definitions of de-identification. Encrypted data is likely also in that category. Synthetic data is a different kettle of fish. Synthetic data may actually fall outside of data protection legislation altogether. But all of these privacy preserving technologies are not satisfactorily dealt with yet in data protection laws because they are relatively new and evolving. And so I think this is another area where it'll be interesting to see how definitions and approaches are adapted. Now, I don't want to take more than my allotted time, so I'll just flag some of the other issues that I had put here. Enforcement and compliance will be a big issue. We're starting to see trends in data protection laws towards much more severe penalties for breaches of the law, which creates some anxiety in the research and innovation communities. At the same time, while this has been driven by some pretty high profile and egregious examples of abuses of personal data, at the same time, some of the more complex uses of large volumes of data may require different approaches to compliance and enforcement. For example, more proactive compliance and audits, which would require changes not just to the law, but also to funding and resourcing of Information and Privacy Commissioner offices. So that, again, is something to watch. And then the other thing I'll just flag very briefly before I stop is access to data. We're seeing a proliferation now of discussions about, as well as attempts to create different data governance bodies, both in the public sector and in the private sector, in order to help govern and manage data. Those are really interesting and positive developments, but of course, harmonization is going to be is a perennial Canadian challenge. Particularly Canadian challenge. And so these are things to watch for, whether it's the Ontario Health Data Platform, the Ontario Data Authority, the Federal Data Commissioner, as well as a range of other potential data governance bodies that we're starting to see experiments with and starting to see the beginnings of policy and legislative frameworks around. So I will stop there. I could go on, but I'm not going to. There's plenty of time for questions afterwards. I think I'll just stop there, having flagged some of those trends that I think are really interesting and worth watching. Thank you.
Thanks, Teresa. That was awesome. And I think you've raised a number of really interesting points that we'll undoubtedly come back to in the Q&A. But now I'm going to turn it over to Stefaan. So Stefaan, over to you.
Yeah. Thanks so much, Michael, and thanks, Teresa, for setting the stage here, because I will pick up where you left off with regard to the access question. And indeed, if we reflect on what's going to be the next 30 years of data, I think it's important to take stock that the main event of the last 30 years has really been the digital transformation, that ultimately, to a large extent, a lot of the data has become digital, and as a result, we've seen this massive datafication of society, as Teresa was already saying, that many, if not all, organizations are now, to a large extent, collecting data that, to a large extent, could be used for other purposes. And the real challenge in the current environment is that we have spent a lot of time on trying to prevent the misuse of datafication and the misuse of data, but we actually also have not spent enough time on how do we prevent the misuses of data, especially in the healthcare context, as a result of the fact that we haven't really figured out how to have access to the data that has been collected in a responsible way. And that's one of the areas that we at GovLab have spent a lot of time on, initially in the context of open government data, but more and more in the context of private sector data, data that was collected by the private sector as a result of new kinds of instrumentation, such as, for instance, wearables. And the question here is really on how do we have access to private sector data for instance, public health research. And that requires a new kind of partnership model, which we call data collaboratives, which are quite often public-private people partnership models where access to data is being made available in order to reuse that data for instance, research purposes. And so we at GovLab have done a lot of work on data collaboratives. We have established a range of them. We have studied about 300 examples in order to really understand what are some of the success factors that matter. And it turns out, that there is no one way of structuring a data collaborative, and that it's really important to think about what is the purpose for which we need a data collaborative, so that you have data collaboratives that are fit for purpose as opposed to nice to have because, anyway, it sounds on paper as something that one should have. But more importantly, what we have found is that the real challenge of data collaboratives is to be systematic, sustainable, and responsible. Because what we have seen is that many of those data collaboratives never scale beyond the pilots. There is no shortage of graveyards with a lot of data collaborative pilots that sounded wonderful, but ultimately only managed to quite often do the pilot's phase and then subsequently didn't figure out how to actually establish a more systematic way of having access to private sector data. Also, we have not figured out how to actually sustain this meaningfully, unless, of course, there is public funding that is made available for those kinds of public goods, right? Because to a large extent, we are talking about a public good kind of environment, which is, as we all know, and especially the economists that are listening today, we all know is famously hard to sustain if we don't have access to, for instance, public funding. And then thirdly, of course, there are real concerns, as Teresa was already referring to as well, with regard to those access models, and that we really have to come up with a more responsible way. And so the real task for the next 30 years is going to be, how do we accelerate data collaboratives in a systematic, sustainable, and responsible way, so that we have access to data that the private sector and the public sector quite often has, in a way that actually can accelerate new research. Now, from our point of view, in order to become more systematic, sustainable, and responsible, there's a whole range of activities and foundations that we need to establish. And again, Teresa referred to a few of them in the governance and in the legislative space. But I will just very quickly, Michael, before you become very nervous that I will go over my time, very quickly raise 6 areas that I think we really need to focus on in order to accelerate this data collaboration for the next 30 years. The first one is that we actually have to become far more sophisticated to express the demand for which we need access for data for. Too often, what we see is that we are driven by the supply of data, i.e., would it not be great if we would have access to data without really reflecting and formulating the questions for which we need data for? And I think we need a lot more sophistication in formulating the questions that matter to society for which we then need access to private sector data. And more importantly, we need to do this in a participatory way so that we not only have data equity, but more importantly, also question equity, that actually those that will be affected by the answers are also part of formulating the questions for which we need data for. And as a society, we are actually pretty unsophisticated in really formulating questions. We are quite often obsessed about the data, but really don't make a good effort in formulating questions, nor are we good in prioritizing questions by engaging a broader public on what are the questions from your perspective we should prioritize, because they might actually affect you in different ways depending on how they are answered as well. And so the first area is really about strengthening the demand by strengthening a new science, as I call it, of questioning that can complement data science. We need question science to complement data science, and we need to do this in a participatory way. The second element, very quickly, is that in addition to strengthening the demand, we need to strengthen and more importantly, professionalize the supply side of data, by which I mean we need to establish a new profession that can actually respond to solicitations for data. And that new profession we call data stewards. And I realize that, of course, data stewards is already an existing concept, which is why we call it a reimagined data steward, an individual, a position, a role that really can respond to solicitation in a systematic, sustainable, and responsible way. We get quite a lot of requests because we do a lot of work with the private sector in order to inform them on who they should contact in the private sector with regard to access to data. Quite often we get calls and says, you work with organization X, can you tell us who to contact? And then most of the time, I have to tell them, good luck finding out, because there is no role, no function within the private sector quite often that actually has a mandate and a skill set to really respond to solicitations. And so that's where this reimagined data stewardship comes in, which is really about stewarding data, but also stewarding partnerships. It's about stewarding internal resources. It's about stewarding sustainability, really making sure that this can be done in a sustainable manner. And then lastly, it's also about stewarding the insights, because it's not enough to just create insight. It's also about making sure that then action is connected with the insight. Now, the third element, once you have a good demand and you have a more professional supply, then it's really about how do you match demand and supply in a responsible way. And that's where governance comes in. And we need indeed a lot more experimentation, but more importantly, a lot more streamlining in order to match demand and supply. And that involves new kinds of institutions, such as intermediaries or data collaboratives in general. But it also involves, for instance, streamlined data sharing agreements and new kind of licensing agreements that really can accelerate access to data in a trusted and in a fair kind of way as well. Then fourthly, and then here I piggyback on what Teresa was saying with regard to consent, we also, because we are talking about the reuse of data that was collected for one purpose for another purpose, and where consent, frankly, is very limited from my point of view in actually identifying preferences, we need a new notion of a social license, where we actually can engage society at large or specific communities to really identify what are their preferences and how can we co-design access to data that meets some of their values and some of their expectations. And that also means that in some areas, individuals and especially groups might actually want to express for which we need more data as opposed to less data and more activities as relates to access. My worry with consent is that it's very individual based. And as a result, we miss actually that collective societal kind of debate about what are the kinds of use cases for which we need more data, not just less data. And I think absent that kind of social debate, social license, consent is quite often failing to take that into account. In addition to social license, we also need to invest more in decision intelligence, which is an element that we are doing more and more work around. And as already mentioned, it's very frustrating to set up data collaboratives that generate wonderful insights and no one acts upon the insight, right? And I think we need to spend a lot more effort for the next 30 years if we want to have data to be impactful. We need to spend more on how do we go from data intelligence to decision intelligence, and how do we shape the decision ecosystem in a way that can become more data driven, make it also more, by the way, accountable, so that if there is insight, what's your responsibility to make sure that you actually use it? But more importantly, we also need to understand what are the kinds of constraints in a decision environment that data needs to be taken into account. And then lastly, Michael, just to round it up, and of course, these are just a few areas that I think will be important for the next 30 years as well. But lastly, we need actually a lot more data about the use of data. By which I mean is that quite often I find it surprisingly that the data ecosystem is very poorly data driven. We actually don't measure what is the impact of data, what is the impact of actually data collaboratives, what are the ways we can actually accelerate the impact of data in more impactful and effective ways. And so we need additional research about data that then can make data more evidence-based. And that's quite often failing at the moment. A lot of the discussions about data are quite often ideological, as if more data will automatically be better, or data is an inherent positive or negative, by the way, asset. And I think we need to be more sophisticated and evidence-based moving forward. So with that, over to you, Michael. These are just a few observations on how we can actually accelerate data collaboration for the next 30 years.
That was terrific, Stefaan. Thank you. And I didn't get nervous at all when you described list of 6. Don't worry. I knew you'd come in on time. Okay, so last but not least, we have Andrew Morris from HDR UK. Over to you, Andrew.
Terrific, and greetings from London, actually. I'm actually in Whitehall, which is, as you know, they throw very good parties there. So, I want to build, I do have a few slides which I'll show. Just let me know once you can see that.
Yeah, we can see that.
So I'm going to build on what Stefaan and Teresa have said, and I'm going to say the next 30 years is full of opportunity. But what we need to do is build and maintain the integrity of a trustworthy health data ecosystem that can accommodate data in all its forms. And I'm going to suggest the next 30 years, as the pandemic has illustrated, we need to do this globally. This is not a national challenge, it's a global challenge. So, and I'll canter through this because we need lots of time to question. And I'm going to suggest that we should be doing this at the national level, but federating internationally. But we'll see a convergence of healthcare research and innovation. And this is about sustainability of health systems. Secondly, I'm suggesting that data science is the catalyst for change, but building on Teresa, I'm going to suggest that trustworthiness and demonstrating trustworthiness is the golden thread throughout all of our endeavors. But before that, happy birthday, ICES, you're 30. So born in 1992. Michael tells me he was 5 at the time. But he'll remember, Michael, who was the Prime Minister in 1992? Do you remember?
I'm going to say Trudeau. Have I got that right?
Wrong again. Brian Mulroney.
Oh, darn.
Yeah. So there's the Prime Minister. But just recall what computer science looked like in 1992. So that was it. And that was an expensive, fully spec computer with a 14 megabyte hard drive. So how the world has moved on. And the whole thesis is we're on the cusp of the fourth industrial revolution as we apply it to healthcare and biomedical science. And it's this blurring between computational science, biology, physical science, and social science. And our challenge collectively is how do we deploy the fourth industrial revolution to healthcare in a trustworthy way? Because we've seen so many examples where it's exploited and causes harm. So Michael asked me to give you a case study. So we're trying to do this in the UK, but we're in the foothills of where we need to be. But just to give you a sense of where I think Stefan's 6 principles are absolutely right. So our mission is to unite the UK's health data to enable discoveries that improve people's lives. And we want to run studies on up to 66 million people in anticipation of the fourth industrial revolution. And those are our funders, our core funders. And actually we are modeled on ICES. It's fantastic, the collaboration we've had, and we learn in a very reciprocal way. So we're not a funder, we're independent, but what we're trying to do is not be a data controller, but drive the standards, the governance, the public engagement, the trust, the legal implications of federating data across a trustworthy health data research ecosystem. And our ambition is about detail in terms of diverse data and scale, but most importantly, longitudinal data. Because if one has exposure and outcome, one can use that for diagnostics, prediction, therapeutics at scale. So can we do this on a national scale? Because our anticipation, I think healthcare is behind other sectors because other sectors are more mature in terms of data ecosystems. And currently we have a very much a one-to-one trusted relationship where researchers phone up their friendly data custodian, but we will move to a more mature ecosystem where we'll have a many-to-many relationship. But that requires trustworthy automated systems in terms of governance, policies, technologies, the definition of APIs, and the ability to demonstrate trustworthiness in terms of competence, honesty, and reliability. Because that is the UK health data ecosystem. It's pretty complex. Not one of those organizations has all the skills, the expertise, the data, or the infrastructure, data, and services to answer some of the most pressing societal questions, whether it's multi-morbidity, inequality, climate change. But collectively, if we can engineer the data ecosystem, the scale of the scientific endeavor is unimaginable. Because the opportunity is to link personal data, social data, environmental, health, biological, genetic at scale to create fair data services. So that's the sort of script. I think that echoes what Stefaan was saying. I'm going to try and convince you there's a triple aim in this. You need 3 things. Firstly, research, data, infrastructure, and services. Secondly, learn as you go. Don't build it and hope people will come. But it was Stefaan's point about data integration for a purpose, getting the questions right. And lastly, the social infrastructure. How do we build the community and the partnerships in a trustworthy way? So very briefly, in terms of data infrastructure and services, there are components, there's the technology and the data, but there's the wrapper around it, the trust and transparency. So that's governance and public engagement in everything we do. There's the understanding the data stewardship, the data engineering. How do we really create well-defined, well-curated data sets? To do that, final pillar is capacity building. And we've made some headway in doing that. So we've created a community of over 70 data controllers. We have a single innovation gateway where you can search metadata on 700 UK data sets. Anyone in the world can search that. Data quality, governance and ethics, capacity building, leadership in public involvement. But key to it is to have these demonstrator programs, which not only answer societal challenges, but help clean the pipes of the infrastructure in terms of the ethics, governance, public engagement, technology. And we've selected 8 from molecules to electronic health records through pandemics through to societal environmental determinants of health. And finally, it's about the people. This is a people project, not a technology project. How do we work in partnership globally, regionally, and nationally to actually drive change? Other industries do this very well. I could send Michael 100 Canadian dollars in the next 3 minutes. I'm not going to, but it's because his bank and my bank subscribe to the SWIFT system. But in healthcare, we've got this siloed, fragmented, unstandardized approach. So very quickly, does it work? So this is a case study. We're still in the foothills of where we need to be, but COVID-19 hit the world and we were fragmented. There was a need to map the data sets, to provide the infrastructure, data services, and governance, and make the data fair through a single shop window. So this was the UK COVID data tapestry in June 2020 across England, Scotland, Wales, and Northern Ireland. That's what it was a year later. And you can see that we made data fair, not only in terms of primary, secondary, tertiary care, but also viral genomic data, social science data in terms of COVID opinions survey, business impact of COVID survey. So it's a really multi-dimensional data landscape. And it was so important we worked with the publics to say how we were using data on 66 million people. So we reported to all the governments in the UK on a weekly basis, giving them a state of the nation report on health data science. And this is a busy slide, but it shows our trusted research environments. It shows 400 research projects taking place. It shows how long people were taking to access data. And importantly, it showed outputs. So what were those outputs? Very briefly. So some fantastic colleagues, Aziz and Julia, looked at national vaccine effectiveness and safety using nationwide data sets to look at these new drugs, whether it was the Pfizer, BioNTech, or AZ vaccines. Did they work? So these were just a few examples of real world vaccine effectiveness, vaccine safety, waning of vaccination, the mortality associated with Delta, and the effect of SARS-CoV-2 in pregnancy, giving you a flavor of, if you've got that near real-time data, how it can feed into policy very quickly. And it received a lot of international attention. Secondly, non-COVID harm. More people die from cardiovascular disease and cancer in the UK each year than have died of COVID. So again, looking at national data sets led by Kathy Sudlow, this was the effect on cardiovascular admissions for acute coronary syndrome, really beginning to articulate non-COVID harm in the entire population of the UK. Trials, and I'm sure the recovery trial, Martin Landry led the clinical trials team of HDR UK with Peter. The recovery trial was very simple because it used routine data for ascertainment of outcomes, mortality, hospitalization, and other morbidity. So a data linkage way of enabling trials. Very simple because the data systems were already in place. So about 40,000 people recruited to recovery. And you'll recall the effect of dexamethasone, which arguably has saved 1 million lives globally because of the ability to link data. Surveillance, this is Ian Diamond's the infection survey, but the ability to link surveillance or cohort data to routine data, and this has really been the lodestar of the UK pandemic response, being able to look at long COVID, 1.1 million people living with long COVID, and the fact that people were readmitted after discharge, so being able to start to follow the risk stratification of COVID infection. Similarly, with viral genomics, the UK led, Sharon led COG UK, 1.1 million viral genomes, but we've now enabled this into an outdate data analysis platform which actually will provide a platform for future pandemics. Team science, this is not about individuals. It's great to see, these are all alphabetical, the people who've contributed to this. And it's been invaluable in identifying, tracking new mutations, new variants, not only in the UK, internationally. And this convergence of care with research and policy has really transformed the way we look at data. Because instead of being slow and sclerotic, the research community has helped actually define evidence-based decision-making. And I would argue we should be doing this internationally, and a project we're doing in partnership with Megan Azad at Manitoba and many other colleagues is international data sharing of COVID. And we've now, through partnership with the Gates Foundation, got 12 international driver programs across 42 countries, looking at how we look at the infrastructure, data, and services to allow collaboration, as well as the science. And this is the work that Megan is co-leading, the IPOP study, which is just fantastic, which has looked, I'm flicking through this quickly, at 25 million births across, I think it's 25 countries, being able to scale this internationally. So I think that's where we are, but how do we build an ecosystem? This is going to change very quickly. It was Gates who said, you overestimate what happens in 2 years, underestimate what happens in 10. And I just flicked through the future technology today, because I think there are other pressures on the system. Firstly, big tech. Healthcare is ripe for disruption, and how we work with big tech, I think, in a trustworthy way is going to be a big issue. And we're already seeing that with some of the major players, and that may actually displace the traditional model of the pharmaceutical industry. Secondly, building on Stefaan and Teresa, new data types. So COVID-19 has accelerated the adoption of telemedicine, and we'll see more diagnostic tests being done at home, and industry will actually curate a lot of these data in terms of connected devices. So last year, it is argued, was the rehearsal for the remote patient monitoring. Also, we'll see an acceleration in the use of AI and medicinal informatics in drug discovery, and a closer integration with synthetic biology, genetics, medical imaging, these unstructured and new data types. And we'll see a major progress in terms of neurodegeneration and new artificial nervous systems using AI and neural implants. So I'll stop there, but finally, this is Thomas Dorber, who was the architect of Framingham, that study of 5,000 people in Massachusetts, who said participants were treated like gold. They must never wait, must be thanked by everyone that they meet with. And I think Dorber had it right. We have to put the patient at the heart of everything we do, because that's why we're here. So I'll finish there, Michael, with the comment that it's time to collaborate. It's time to build data ecosystems which are trustworthy, but the challenge is global. So thank you for listening.
That was terrific, Andrew. Thank you. And thank you to all three of the speakers. I object a little bit, Andrew, to you offering to send me that $100 and then say you wouldn't, because I'm not actually convinced that system works. So I think you should run the experiment and try to send me that $100 after the conference is over. All of you spoke in various ways about trust, about trustworthiness, about consent issues and so on. And the private sector has come up a number of times now in these discussions, whether it's around wearables, Fitbit data, and so on. And I wonder, are those, as we move into the future and the role of the private sector becomes more and more immersed in this, is there a fundamental conflict between increasing the trustworthiness of these systems, whether it's the system as Andrew described it or the data collaboratives that Stefaan described, and the involvement of the private sector in this? It seems to me that in work that we've done and others, that the private sector always seems to be the third rail in terms of trust for individuals. And yet we see people who strap on Fitbits and are transmitting data up to the private sector all the time. So questions to each of you on that.
Who do you want to start?
Teresa, you go ahead.
Okay, I'll jump in. Yeah, so this is a really interesting question. And I just want to highlight, maybe give the example of the uproar we had very recently in Canada over the use of mobility data by Public Health Canada during the COVID-19 crisis. So they used private sector mobility data that had been de-identified, and there was an enormous public outcry. It goes a little bit to one of the questions I see in the chat, which talks about data literacy and the gap in data literacy, because this was an interesting example of a trust issue, one where, first of all, I think there was a very poor understanding of what the data was, how it was curated, how it was being used, and what the privacy implications were, which I think were relatively minimal. And there's just been a report issued by the House of Commons Ethics Committee on this, and I think their conclusions are similar to that. But I think what it revealed was a profound lack of trust, a profound data literacy gap, but also with parliamentarians who were outraged or expressed outrage as well about the collection and use of this data. And I think it also shows a lack of trust, which we've seen before in Canada, in the public sector, in government use of this data, in a context in which there seems to be surprisingly considerably more trust in how the private sector is dealing with this data. There wasn't a big backlash against TELUS, whose data it was and who had been collecting the data from consumers or individuals. The backlash was against Public Health Canada for the use. So I think the trust issues are really complicated as between public and private sector. And I think we really need in Canada to start unpacking some of these, because it's not the first major pushback against public sector use of data that we've seen. And I think it shows some significant issues, trust issues in government and public sector uses of data, and perhaps challenges around transparency. And there are issues around transparency and public engagement, I think, that are really important in this context. So there's that complicated context. There are some very high profile problematic actors in the private sector that collect and use data with apparent disregard for data protection rights. But there are many good actors who are, and this goes a little bit to the question, to one of the questions in the chat about organizations that are trying to navigate this area. There are many private sector organizations that just want to do this right and are struggling in the Canadian context because the legislation is not up to date, because it's ambiguous, because it doesn't provide enough guidance or framework. And so I think that legislative change is also one of the pieces that's necessary in this context to create an environment in which those private sector actors who want to do this properly, securely, safely, without risk of fines or penalties or class action lawsuits, who just want to participate in this ecosystem, know what rules they need to follow, know how to do it appropriately. So I would say it's complicated, which is a typical lawyer's answer, I suppose. But there are a lot of these are a lot of the different moving parts in this context. And it's not just, trust private or no trust for private, trust for public. I think it's a very complex context.
Yeah, and again, I want to build upon what Teresa said, is that A, it's complicated, but B, it's also dependent on a variety of variables, right? And again, it goes back to also the discussion about how much data literacy do you need in order to have a meaningful conversation. And so here, for instance, in New York, we developed during COVID-19 something called the Data Assembly, i.e. Citizens Assembly around the reuse of data for COVID-19. And we invited both experts, but also New Yorkers to be part of that kind of deliberation. And here, it depends on how you introduce the topic. You don't need to know fully what is aggregation, what is full anonymization. You actually do need to introduce a set of scenarios and say, how would you go about this kind of scenario? And then it turns out that, if you engage with the public at large, they're actually quite sophisticated, because they don't assume this as something that they are either against or for. Their basic answer is, it depends, right? And I will trust depending on how it is designed. And then the design questions are really about, A, why do you need the data for, right? So what are you going to use it for? Who's going to access the data, right? Because that's already an element of trust. It could be private sector data, but accessed by researchers, trusted public researchers, for instance, and that's already a different equation as well. How long are you going to have access to the data? So the when question. How are you going to have access to the data, right? Is it actually transferred, or are you just going to have access? And then where, right? And what kind of jurisdiction will this take place? And what are the kinds of safeguards that are in place vis-a-vis that thing? And so, and then this is just a simple, anyway, reflection on saying that there are X amount of variables, right, that determine whether you trust it or don't trust it. And we need to have a much broader conversation about what are the variables that contribute to trust, right? And then how do we design those trusted kind of environments? Because it's not going to be an either or, it's going to be, it depends on how it is being designed.
Yeah, so just to echo Teresa and Stefaan, it is about a couple of things: demonstrating trustworthiness, and Baroness O'Neill here defines trustworthiness is about being honest, reliable, and competent. And another point about trustworthiness, which I think is important, one doesn't build trust. Trust is earned or given by someone else. So I think we're duty bound to be honest, reliable, and competent. And in dealing with the private sector, I think there are two key issues that have come out. Firstly, privacy, to ensure that confidentiality and privacy is maintained. And the adoption of privacy-enhancing technologies, trusted research environments, safe projects, safe places, safe people, safe places, safe outputs is part of that. But being able to demonstrate transparently privacy. The second one is, when we've done deliberative engagement, is benefit share, because people, a lot of the industry, if it's AI algorithms, if they're accessing a million image data set, say CT brain, the public pound has curated that for probably about £500 million. And what the public tell us, that interaction with industry needs to be fair, and we need to define benefit share that is equitable back to the public good. So I think demonstrating privacy, and being very transparent, and secondly, this concept of benefit share, so that the contractual deal is perceived to be in the public good.
Terrific, thank you. So one question in the chat relates to some of the issues that we've talked about in earlier sessions today around equity and the challenges for with specific racial or ethnic communities or other communities that were certainly seen during the COVID pandemic, and whether by virtue not only of inclusion, let's say, of private sector data, which may only represent part of the population, or not fully represent the entire population, or in the example of Stefaan, the data collaboratives, where to the extent to which that data is fully representative of population may vary widely. How do we address those equity issues in this kind of forward-looking framework? And to what extent does not fully addressing those affect the whole issue of trustworthiness and social license and increase the fragility of the enterprise? And I put that question out really to anyone. Maybe I'll start with Stefaan this time.
Yeah, no, I think you're fully right. That's one of the biggest challenges of the current data ecosystem, right? Is that you have this kind of inequity in the data, but also in who benefits from the data. And I do want to anyway echo what Andrew was saying, is that one of the key elements that anyway through our data assembly that we heard over and over again was equitable benefits, right? So that actually those that benefits or the beneficiaries need to be equitable, right? And it goes anyway across the data lifecycle, right? Because it's not just about how do we make sure that everyone is represented in the data set and that there are no invisibles that typically already are the ones that are excluded in society. But it goes, as I mentioned, it goes also about the earlier stages on who actually defines what is the question and the priority of the question, right? Because a lot of the research is determined by, anyway, a variety of stakeholder engagements, but quite often those stakeholder engagements are in itself not equitable, right? And I think we need to really do a better job in actually really formulating questions in an equitable way that then can inform data access for those questions, and then really take the equitable aspects into account when we assess representation and sampling, for instance, of the data. But then more importantly, again, at the latter stage of the data lifecycle, we need to also understand is that how is the insight going to be used in an equitable way, right? And so just to, anyway, reiterate, Michael, is that we need to think about equity across the data lifecycle, not just at the point of, for instance, collection. And I think that's really the exercise that we need to engage in.
Teresa, shall I chip it? Yeah. So, this is a burning issue, and there's a risk, especially as we adopt new computational science and statistical approaches, that it will accelerate inequality through health data poverty if we don't have representative data sets. And I would actually quote a guy called Joe Heinrich from UBC, who described the weird world, because he said that 80% of the data that we use in biomedicine come from 12% of the world's population. And it's weird because it's Western educated, industrial, rich democracies. So we have a real challenge in terms of, Stefaan says, representative data sets. I would also flag that equality and diversity also applies to our workforce, giving opportunities to all colleagues to flourish and build a career in health data science. And something that has been a remarkable revelation to us in the UK is a Black internship program that we've run. And it has been a complete stellar success. And colleagues have moved on to fantastic career positions right across the UK ecosystem. So I think there's an issue around the data, but also in terms of the teams who are going to drive this forward in the future.
Yeah, and I think those are both great insights from Stefaan and from Andrew. What I would just add to that, I think, as data are increasingly used in artificial intelligence and in that context, is that we have to be careful not just to ensure that the data sets are representative, but that we also query what the data is actually telling us, or what it's actually about. And what I mean there is, for example, that you might have data about, or that represents a diverse population, but what the data, the actual medical data might reflect is doctors who don't believe symptoms that are being reported by patients, doctors who dismiss certain symptoms in certain populations. I mean, women, this has been an issue for women in a variety of contexts, for example, or patients who are misdiagnosed because of stereotypes or biases. And so there also has to be not just the representative data, but an understanding that some of that data may actually be flawed in terms of what it is telling us. And so it is, I think it's a really complicated set of challenges that we face, but they're important ones.
Great, thank you. We only have about a minute left, so maybe just kind of a short snapper here, response from each of you. It strikes me that these are really complicated topics, and in fact, that governments, that we need governments to take leadership roles in this space, where in all of our countries, and ultimately it's governments, policymakers, and funders that are determining the investments in things like research infrastructure or data infrastructure that's going to drive much of this work. So as we look to the future, what would be the one piece of advice that you would have for decision makers and policymakers, let's say in Canada or really anywhere, about how they need to be thinking about this challenge going forward? I'll turn over to Andrew first.
Advice to policymakers is firstly, see this as a long-term societal benefit. This should not be funded on short-term repetitive grant cycles. It's like building the James Webb Telescope or CERN. So having a long-term view. Secondly, put the patient and the public at the heart of everything you do as you shape the policy. And thirdly, acknowledge that not one sector, including government, can do this themselves. It needs a very collaborative approach to innovative policy that brings together the public with public sector, industry, academia, and the third sector. So those would be my advice. And lastly, fund it.
Terrific. Teresa.
Yeah, the funding is important. It's great to have all get it all worked out on paper and no money to support it. So, I'm tempted in the Canadian context to say briefly, get on with it. We've been waiting for legislative reform in some sectors in Canada for a long time now for reform of data protection laws, and it just needs to move faster. The other, recognizing that we've had a pandemic, there have been other issues on the government's agenda, but get on with it. And the other thing in Canada, in the Canadian context, is a need to harmonize and to work hard to harmonize across federal and provincial sectors, because this is something that has held us back in Canada. And I think we really just need to find some way to make it work.
And Stefaan, last word to you.
Yeah, sure. And I think all those elements are important. And I think it's important to invest in the policy infrastructure and the technical infrastructure, but none of this will succeed without investing in the human infrastructure from my point of view. And that's where I would advocate for really thinking about advancing data stewardship at all levels, because as already was mentioned, this is complex. And you actually do need to have like a professional way of thinking about all the variables, all the complexities, and coming up with solutions that are fit for purpose. And that's where you need that kind of profession that can really understand what is fit for purpose, what is responsible, and how can we get that level of trustworthiness, as indeed Baroness O'Neill has defined, to actually reuse data, because that's, from my point of view, the real opportunity and the real headache. Reuse data in a way that is systematic, sustainable, and responsible.
All right. Well, listen, thank you, Teresa and Andrew and Stefaan. That was a terrific panel, 3 terrific presentations and a Q&A. You've laid out some major challenges for us. We look forward to working together with all of you on these over the next 30 years or 40 years or however long it takes. This is for sure one of our great challenges as a society going forward. So thank you all for participating in the conference today. Okay, so that is brings us to an end to the formal part of the conference today. It's been just a fantastic day for me. I'm hoping it's been a fantastic day for all of you. I found the discussions and conversations from the very beginning, from the workshops on, to be superbly stimulating and interesting and thought-provoking. And we've got a lot of work cut out for us, let's face it. But we also have a lot to celebrate, looking back over the last 30 years, and a lot to look forward to over the next 30 years. I want to thank everyone who came to the research forum today, who participated in the forum as presenters, as moderators. I also want to thank our core partners, the Ministry of Health, the Ontario Sports Support Unit, our research forum sponsors, IQVIA, iSecurity, Faskin, and Mark and Clerks. And special thanks to our communications team, Nancy McCallum, Anu Yadav, Zanetta Sharneko, and Naveen Saleh, who put on a terrific conversation along with a team from face-to-face communications. I also want to thank the Content Planning Committee, the ICES students, scientists, and staff who participated in determining what we would be presenting today. And a big announcement, mark it down in your calendar right now. Next year's research forum is going to take place on Thursday, May 11th, 2023. We will send out, of course, reminders, but mark it down now because you want to be available and free for this event next year. We've had a technical challenge with reconnecting with Wendy Phillips. Unfortunately, we haven't been able to reconnect with her due to some internet issues, so we won't have her here for a closing prayer. So I will simply say a final farewell, which is that we are sending out a survey for your feedback on this conference. We'd really love to hear from you about the conference, about what you thought of the content, how we can make it better for next year, the format, and so on. So you'll be receiving a survey from us shortly. The recording of today's conference will be made available as well online in a couple of days, and you'll hear about that. And so with that, I close this year's ICS Research Forum. I thank you again for participating. Wish you a great end of the day, and look forward to seeing you all again next year. Bye for now.